We will start.
Yes, ma'am. Please start, ma'am. Komal, ma'am, you are muted.
Nilimba, count.
चालू कर.
Okay. So, good evening, everybody. And this is a really, really wonderful feeling to be at the ICOG certificate course on medical disorders in pregnancy. And today we are at the day 2 after a very, very successful day 1, which was held yesterday with more than 10,000 plus registrations, 500 plus people online, and such active audience and a lot of interactions yesterday. We are now beginning with the second day course, and second day also we are targeting. Yesterday was a hypertension, which is the most commonest medical disorder in pregnancy, and today is hyperglycemia in pregnancy. And that too is really, really very, very important. Because why it is important, as in, like, India is almost going to become a diabetic capital of the world, and we are seeing more amount of patients with hyperglycemia in pregnancy coming to us at a very, very all stages. And that is the reason we have uh, extensive coverage today of this hyperglycemia in pregnancy with galaxy of speakers from Dr. Hema Divakar Madam, Dr. Vidya Thobi, Dr. Charmila, Dr. Sujata Mishra, Dr. P.K. Saxena, Dr. Sita Ramurthy Pal, followed by an interactive panel discussion wherein we have case-based scenarios. So we all are glued to attend this comprehensive ICOG certificate course. And this is all because of the vision and the mission of our ICOG chair, Dr. Parag Biniwale. So he's here along with our secretary, Dr. Sarita Bhalerao. And I would ask Dr. Parag Biniwale to address our audience.
Thank you, Komal. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to address the audience on the second day. Yesterday, we had a fruitful session on hypertensive disorders in pregnancy, and today we are going to discuss a lot on hyperglycemia in pregnancy. And the opening batsman, I welcome Dr. Hema Divakar, who is one of the pioneers, I should say, who made Foxians familiarize what DIPSI is. And Hema, I'm happy to tell you that there are so many people now, after your tireless efforts, who are following the DIPSI test, and we are able to diagnose more and more women who have GDM and other forms of hyperglycemia. Thank you for being there today. And today we have the registrations have crossed almost 1,500. So we look forward to a lot of people attending this. We want more and more people to attend it because we are actually identifying areas which are so common, but they are still so neglected. So thank you very much. Happy learning. And I would ask Dr. Sheila Mane, the chairperson-elect, to say a few words. Sheila.
Yeah, good evening, everybody. As mentioned by Dr. Komal and Dr. Parag already about today's program, and the first speaker, none other than Dr. Hema Divakar. And I must share with you that in Karnataka, every PSC medical officer knows about this DIPSI, and it's been done. And it's very happy, with the happy note, I must tell you that so much of awareness is there amongst the health personnel, and it is mentioned on the Thai card. Mother's card is called as Thai card in Karnataka. So it's been happening very, very effectively. And all thanks to Dr. Hema Divakar, and she's the opening batsman today. And Dr. Komal has already mentioned about all the speakers. And I know that all the speakers, today's speakers, everybody like Vidya Thobi in nutrition, Charmila for screening, Sujata Mishra and Sita, and everybody have been working for this cause. And all of us, we know that the incidence is rising. Roughly, I can say even today in a government institute, I find it is almost now 20%. And what we are seeing is more of a type 2 diabetes now. Okay, even the percentage is on the rise of a type 2 diabetes, and it gets detected because we are screening them in first trimester. And that goes a long way because, we control it early, and it will definitely help to have a better outcome, maternal as well as perinatal outcome, as we are screening in all the trimesters, and it starts in first trimester. And we are also getting nowadays patients who are juvenile diabetics. Okay. Yes, now the thing is, like, it is diagnosed early, it is under control, so they are becoming pregnant and they are also coming. But mainly our duty is to diagnose it during pregnancy. And I think today's program with the topic selected by Dr. Parag will definitely throw so much of light on it. Now, as you said, Komal, that we have so many registrations, but so many people attend because many are in institutions. So they are sitting together, they have one monitor where all the people are, so those who have registered will attend. Why we get less number is because they are sitting with one monitor and then they are listening. For post test, they will do it from their own instrument. It is like that. So that shows, in fact, yesterday, I think I did not leave anybody. All my postgraduates had to attend and they have attended. And it was a question today in exam, in DNB exams, PIH prediction, prevention, management, everything. I mean, we know that hypertension is now the first cause of maternal mortality and morbidity, and NCDs are on the rise. So, best wishes, and thank you for the opportunity. And I welcome everybody for this today's certificate course. Thank you.
Thank you. Thank you so much, Sheila Mane Madam, for your lovely, wonderful words, and Dr. Parag sir. And yesterday, Dr. Charmila, as a convener, had managed it so beautifully. And we have our co-convener, Dr. Achra Batra, also, who has joined today. So welcome everybody. And Dr. Jayarajani Kamraj will be our coordinator for the day 2. And so I hand over to Dr. Jayarajani to begin with the academic session. Thank you so much.
Thank you, Komal. Thank you. I thank ICOG, Madam, and Parag sir for giving me this opportunity to be here as a coordinator for this session. Without wasting much time, we'll start and move on to the academics. I have the great pleasure and honor to introduce the chairpersons of this session, first session, Dr. Poonam Goyal. Madam is the chairperson of the Foxy Safe Motherhood Committee, ICOG Governing Council member, and she's an executive member of AOGD, and she has a lot of authorized books edited in high-risk pregnancies, and she has got many awards. And we welcome you, Dr. Poonam, to chair this first session. And we have Madam Dr. Ranjana Khanna, who is the National Vice President of Foxy in 2017, and she has achieved the Foxy Achiever Award in 2022 and Foxy Dheera Award in 2022. And Madam has achieved the Dr. D.K. Tank Reproductive Healthcare Promotion Trophy on ACOG 2015, and she has been the Smriti Nelan Award in 2013. We welcome you, Madam, to chair the first session. And over to you, the chairpersons, for introducing the speakers of the first session.
A very good evening to everyone. And as we all are very well aware, and it has been talked about, that the increasing incidence of hyperglycemia in pregnancy and the trend is very alarming. And for that, today we have a wonderful speaker who's so dynamic, and she has actually created so much awareness of this. We all know Dr. Hema Divakar. She's the medical director of Divakar's Hospital, CEO and chairman, Asian Research and Training Institute for Skill Transfer, chair of Well Women Healthcare at FIGO, Dean KCOG, Karnataka College of ONG, President Karnataka AHP, ex-vice chair for FIGO PNCD Committee, past president of Foxy 2013, an advocate for delivering quality healthcare, convener of Manyata, an opinion leader and an influencer for social and legal issues relating to women's health. We all know that Hema ji is an awesome speaker, very dynamic, and I would think all of us are waiting to hear her talk on the rising trend of hyperglycemia and pregnancy. Over to you, Hema ji.
Sure. Thank you very much. First of all, at the outset, a huge congratulations to Dr. Parag Beniwale, the chair who has so seriously instituted these certification programs, which are going to be immensely helpful. We've been telling FIGO since the last 5 years that just one-off webinars will not do. If you get the target audience who are very keen, very serious, very committed to give the exit exams, as it were, then the nuances they will very carefully listen to, and they will definitely translate this competence and confidence into their practice. So a huge congratulations to you and Sheila, who's stepping into his shoes very, very soon. It's like continuum of care. This trend will continue even much more stronger. And I love the way Komal said that response is so overwhelming that you have created the kind of buzz to get people on board. So with my very fond regards to Poonamji and Ranjana, whose birthday is in the offing another week from now. I do remember. I will wish you on time this time. And Jai Rajani. Komal did not want to leave the Raja Rani, so it began. I mean, notice that. So big shout out to all my friends and extended family here. So when Komal rang me and said, "Oh, Komal, why this topic now?" Everybody knows. Everybody here will say, yes, the trends are rising. So what's the big deal? Because the trends are rising and the solutions have to be kept in mind across the life course. Obesity in adolescence will magnify into something else in the reproductive. In the reproductive, GDM today is NCD, tomorrow Sheila already mentioned type 2 diabetes is like really on the rise. So it's a wellness wheel which goes round and round, troubling us right across. And as a division director of the women's healthcare and wellness at FIGO Wellness on Wheels is what we produced at the Paris Congress. And now it is our dream to get this wheel to reality in practice. We want all practitioners not to lose an opportunity to do the best at every point in the life course of the girls and women. At whichever stage she enters the wheel, you have to prepare her for the next stage in life, and that applies more. And when other professional organizations say, "Oh, Foxy is so active, why you guys are so hyper?" I said, because it's hypertension, hyperglycemia, everything so hyper is happening in our field, then what we can do? We have to live up to it, because alarming trends are happening. And see, we see China, but then India seemingly in 2021, it was half the numbers as in China, but we are really surging ahead, because everybody here knows fertility rates are stagnating and decreasing, but the women beyond 40-50 years, they are living through their diabetic menopausal age group. So we are adding a lot into the population in a very dangerous way. The worst part in our country is, as many diagnosed cases are there, those many undiagnosed cases are also floating in the population. Because for Rotary, we did a massive project where we did about 7,000 plus men and women who were getting the sugar test first ever time in their life. And we found an alarming 43% who were dysglycemic and frank diabetes type 2 who did not know. And we were feeling a little bad that we created so much anxiety in them, putting the diagnosis into their head, because ignorance is bliss. You see, they didn't know, and they were quite cool. Muh meetha karo is not going to be what they will adhere to after they know their diagnosis. So the growing epidemic of diabetes, how half the population who are women are contributing to this growing epidemic, because it all starts with GDM. Almost everybody who is diagnosed as a GDM, if they're not given proper advice and not done the annual checkups forever after, half of them, more than 60% of them, are going to translate into type 2 diabetes. So 1 in 12 Indians, out of which 65% are women. You see more number of women because most of these cases arise, the spotlight is thrown on them in pregnancy, and then more than 65 years, we have lots and lots of population now. So 12 million are adding. So it's everything is in mega scale, you see, and the projections are even more alarming. From now to 2045, the time moves very fast. We'll have more than 134 million diabetics. Coming back to the origins of this in women, at least most of the women, compared to the global prevalence, Middle East, North Africa, it's 1/4. For everything we occupy the large portion of the pie, as we call. South Asia, Southeast Asia, also 10 to 20%. Europe and North America, they say generally 6 to 10%. In India, why the range we are telling 10 to 20%? Because now we are beginning to recognize that unless a woman is tested, we will miss the cases. And even today, after all these, credit which we are taking for sensitizing the practitioners for diagnosing it on time, diagnosing it early, preconceptual diagnosis, infertility cases with obesity, the dysglycemia diagnosis, moving on to hyperglycemia in pregnancy, still there is only about 48% coverage. Another half of the women who are pregnant are not tested for a variety of reasons. Either the capacity has to be built, the women themselves have to ask for it, and they have to get sensitized enough to raise a demand. Therefore, the range varies. But on an average, you can take it as 20%, which is, 1 in 4 women, if she is having gestational diabetes or hyperglycemia in pregnancy, then really God save us, because we don't have that many providers to do the needful. And of course, the influencing factors are increasing trends in obesity, sedentary lifestyle, and genetic predisposition, because as per Barker's hypothesis, every programming is done in the womb of the mother. The health horoscope is written out there, and then the mothers who are hyperglycemic will produce obese babies and early adulthood diabetes. And if it's a female offspring, she is prone to hyperglycemia in her pregnancy as well. So this is just a comparison between global prevalence and Indian prevalence. As I said, the highest prevalence, Middle East and North Africa, South Asia, where we belong. Urban India, certain states with higher obesity rates have escalating values. So in total, if you have to really count on your fingers, you cannot count on your fingers, because overall prevalence 27.6%, with 6.2 million live births affected by hyperglycemia, most of which are due to hyperglycemia in pregnancy as the cause for these kind of offspring. Rural, urban, once upon a time we said urban is 17, rural is 9, but no longer. Rural and urban, please take it on a common platform. Everywhere, every girl, every woman who is eligible for the testing, you have to anyhow test. So 1 in 6 live births is what we said is born out of a woman with some kind of hyperglycemia, but now the ratio is tending to 1 in 4. So if you see this graph, even the GGI, that is gestational glycemic intolerance, the glucose intolerance, which can soon tilt into gestational diabetes mellitus or hyperglycemia in pregnancy, there is a large number. So tip of the iceberg is 10%, but what is brewing inside is 21%. Overt diabetes who get pregnant after they're diagnosed pre-pregnancy is 1.6. In this, a large percentage, first pregnancy, hyperglycemia in pregnancy. Interpregnancy, nobody has seen her, which becomes a preconception for her second pregnancy, and she is already entering the pregnancy with high sugar levels. This is the reality. So once a hyperglycemia, tag her for the rest of her life. Even if she wants to conceive again, doesn't want to conceive again, you must keep a track on her. The question then is why? It's been experiencing an upward trend. I have said it in more than one term and more than millions, which quoted all the variety of ranges, diagnosed and undiagnosed. Urbanization, increasing obesity comes up again and again. But the prevalence rates are also based on diagnostic criteria. Why we did not discover this before? Because the tests were hard to do, and many believe that this is not a problem in our country. So especially when we train the teams in various hospitals, they're unaware of the DIPSI single step test. Is everybody doing it? Yes, now the balance, it has taken a whole decade, 10 years, by the time we got the private practitioners to do this single step test, which is feasible, to up to about 80-90% of the pregnant women whom they see. But still there is a small lacunae, but in public system, the range is between 48 to 58%, which is not bad. It is better than 2 to 10% of testing which we had before. So the numbers are only adding on. Manyata training program, I'm happy to say, has been a game changer for improving the knowledge and skills. And every staff nurse who is trained under this, what they used to falter in the antenatal care was, what is a single step test? What are the pre-requirements? Half of them said we do random sugar test. Half of them said, no, the patient has to come fasting. So we ask her to come the next day. Some were not sure of the 75 grams, etc., etc. But it did not take much efforts or much time to guide them on how exactly it has to be done. So you'll see Bihar, Tamil Nadu, Punjab, and Maharashtra. The statistics here: before the training, 16% were tested. After the training, 89% of the pregnant women got tested. Tamil Nadu, because the whole thing originated from Tamil Nadu, they were good to start with. 60% were tested, but we got it to 100%. Punjab, 13% were being tested before the capacity building. And once the staff and the teams understood, the scales went up to 70 out of 100 women were tested. Just imagine the difference between 13 out of 100 being tested and missing so many cases, as Parag said. We're picking up more and more, and we're picking up early. 42, Maharashtra is good to go with half the numbers tested to start with, but it increased to 88.3%. So this is a huge shift after initial. So Sheila just said that they all hang around one laptop, and this is what you see, very, very typical in the Manyata training sessions, so eager to learn and so eager to execute that in practice with confidence. And many women, because the government guideline says at 12 weeks and 20 weeks, if nobody is missed out testing at 12 weeks, there is an opportunity to diagnose early onset. Preconceptional counseling, promoting awareness about healthy weight, diet, physical activity well before the pregnancy. Obesity is coming up on almost all the slides. So addressing it, talking about it is easy, but actually getting it into practice is difficult. But there are now some more ways and means by which we can target it, especially through social media, encouraging balanced diet. We just had a massive training program in the region of UP in Shivpur and Chaubepur villages, where clusters of ASHA workers, Sanginis and all were taught how to institute the FIGO nutrition checklist. And when we asked them how much time did it take, because today they were supposed to present to us 10 women whom they have seen, on whom they have experimented with FIGO nutrition checklist, believe me, their time range was 2 to 5 minutes. Madam, in 2 to 5 minutes, we completed this form, and they learned so much out of it, of how to counsel the women and what kind of eating right advice that they have to give. So in conclusion, we can say that healthy lifestyle is the cornerstone. If after another 10 years, if ICOG is holding a program, we must say, once upon a time, it was so high, but because we have bought in the lifestyle and we are diagnosing things early and we are doing it, at least the type 2 diabetes also is coming down, because with the sedentary lifestyle, unhealthy diets, every school, every organization is paying attention to this. Yoga day was there, physical activity, now everybody is sensitized to it. Obesity, everybody has recognized it's not an aesthetic issue, but it's a medical issue, and genetic and socioeconomic factors always blamed. But we have found that lower middle class and poor class people are not eating right. They're eating the wrong kind of food stuff, spending as much money, but they're not aware of what's the right thing. So let's also focus, when we are talking big about the prevalence, hit hard on how we can reverse this whole trend by education, lifestyle modification, early detection, and strengthening our healthcare infrastructures. So with this, I would again thank the office bearers of our esteemed organization, ICOG, and our very beloved chairpersons who have always been supportive to all our endeavors and initiatives. A wonderful opportunity to speak to my people again. Namaste.
Thank you so much, Hemaji. That talk was wonderful, so complete, so motivational. And you have indeed insisted on that though the incidence of HIP has increased, but then so have the awareness and the diagnostic procedures. So making the prognosis better of these patients, the prognosis has definitely bettered. And of course, I think there's a lot of stress now on lifestyle modification, right from a prime minister to, everybody is focusing on yoga day and in healthy eating. And so it has a definite impact on the people. So thank you so much for this wonderful talk.
Thank you.
So, Jairani, is Poonam here or should I continue?
Madam, you can
Continue,
say your
continue,
second speaker,
Ranjana.
ma'am.
I'll continue. I
Because,
think,
yeah, ma'am, because I
Yeah.
couldn't see Poonam here. So
yeah,
I think you continue the
yeah.
introduction
So
of the next
we
speaker,
have
ma'am.
the next talk by a very, very learned speaker, Dr. Vidya Dhobi, a good friend. And in fact, all the three speakers of this session are from the South and extremely talented and very good orators. So I have the pleasure of introducing Dr. Vidya. She is Vice President-elect Foxy 2025, President Kasoga 2023, Chairperson Foods, Drug and Medico Surgical Equipment, and hence she has got this topic that is about nutrition in HIP, Best Committee Foxy Award, and ICOG Governing Council Member, Foxy Champion Award, National Corresponding Editor of Jogi, and she's been a speaker at so many forums and advisory faculty of boards and postgraduate and undergraduate teacher for 30 years. So welcome, Dr. Vidya, for your talk on nutrition in hyperglycemia and pregnancy. Can you see Dr. Vidya?
No, ma'am, actually not joined yet.
Yeah, Ranjana, Ranjana,
So,
there was one
Charmila?
question, Ranjana, in the chat box. Why
Okay.
is the screening still at 48%, despite everything everybody is knowing? But actually, until very recently, there was quite a confusion about various methodology of testing, and the frontline healthcare providers were getting all confused. Ye test kare ya wo test. Some were not sure about the prerequisites or the criteria, which the single step test doesn't require any prerequisites. Some had the mindset that it's selective and not universal testing. But I think in reality, the scorecards from every state is coming. Gradually, they're improving. And the last 2 years has been the maximal improvement. The first 5 years were pathetic. The next 3 years, from 10 to 12% of testing, it went up to 25%, but 25 to further, especially in the private practitioners, which is 60% of our healthcare there, it's gone really way beyond 90%, which is a good score. So we are still, good to go with this, but the reality and the actual documentation still strikes us hard that we've done so much, but enough is not enough. So each one of you in the championship of doing the best for women's healthcare should teach one to make sure that we will proudly speak of universal testing in its true sense. Thank you.
So I think we'll move on to the next speaker.
Ma'am, yes, ma'am. You can introduce
Yeah,
Charmila,
Dr.
ma'am.
Charmila.
I'm
Dr.
calling
Charmila's
Vidya, madam.
CV,
Once
please.
she comes, she can continue, ma'am. You can introduce.
Yeah, we have a
Charmila, ma'am.
wonderful speaker going to speak on sugar testing in HIP. So Dr. Charmila, I think all of us are very well aware and as charming as her name. Director, Aditi Hospital and Parvati Ayavu Fertility Center, Trichy, and consultant, Southern Railway Hospital, Trichy, Vice President, Foxy 2024, Vice President, Trichy OG Society, Secretary, Gestosis India Association, ICOG Governing Council Member, National Coordinator, Foxy UNICEF PCA, Chairperson, Clinical Research Committee of Foxy 2016 to 18. Over to you, Charmila, for your talk.
Okay. Thank you so much, Ranjana madam. Thank you for that very kind introduction. I'll just start my talk.
Oh, Vidya has come now.
Vidya,
Yeah.
ma'am.
Yeah, madam has
Vidya,
joined. I think madam has joined. Charmila, you finish off, then we can
Okay.
have.
Okay.
Yeah.
Charmila, you
Yeah.
do your talk.
Yeah. Thank you, ma'am.
We'll just
So
finish, I think, Dr. Charmila's talk. Yeah.
The topic is newer technologies in blood glucose monitoring. Blood glucose monitoring is a very, very important part of managing a patient with hyperglycemia during pregnancy. It's crucial because you need to prevent complications, optimize the fetal development, guide your treatment decisions, reduce the maternal risk, improve glycemic control, informing about patterns to the patient, needs monitoring to facilitate timely adjustments of therapy, and it's important for empowering the patients who's developed hyperglycemia. The glycemic triad of monitoring is there, where you have the fasting glucose, you have the postprandial glucose, and then the HbA1c monitoring. Fasting glucose is extremely important because you need to manage in all your diabetic patients. Postprandial peaks we know are directly proportional to increased complications, particularly in pregnancy. And HbA1c is a gold standard indicator, but that indicates glucose control over the past 2 to 3 months. But at the end of it, it is comprehensive glucose control, which is very crucial for managing patients with hyperglycemia. So regarding the guidelines which are available for monitoring in a patient who has developed hyperglycemia, according to the Government of India, if the patient is only on a diet therapy, you can check her once in 15 days, her postprandial level alone. And suppose she has controlled herself with diet and exercise, medical nutrition therapy, then you can actually switch on to once a month monitoring. But suppose a patient has been put on metformin or is on a single dose insulin, she will need a fasting testing and a 2-hour postprandial test. And suppose she's gone into multiple dose of insulin usage, it will be the physician's choice of monitoring. But when the patient is even on metformin, remember, you need to check her fasting and 2-hour postprandial every 3rd day. And as far as the American College, the American Diabetic Association and NICE guidelines are concerned, even when the patient is on a diet therapy, she has to be checked 4 times a day, and that includes a fasting and 3 postprandial levels. And suppose she's being put on metformin and single dose insulin, the same form of monitoring is needed. But when she's on multiple dose of insulin, which can happen in a pre-existing diabetic, you need to add 3 preprandial levels also. So a 7-point testing is important when the patient is on insulin, as far as the American College and the NICE guidelines are concerned. And when the patient develops hypoglycemia in pregnancy, these guidelines say the patient has to be monitored daily and not every 3rd day, as the Government of India says. And self-monitoring of blood glucose is very, very important for any patient with hyperglycemia during pregnancy, which can be type 1 diabetes, type 2 diabetes, or gestational diabetes. And as said earlier, when she's on multiple daily insulin dosage, you have to check her at least 7 times a day. And it's extremely important that you do this type of monitoring when the patient is on insulin pumps or a basal bolus therapy of insulin has been started. Because a pre-meal rapid-acting insulin dosage needs to be given and adjusted when the patient is on multiple doses of insulin and she's a diabetic who's been, she was a diabetic before she became pregnant. But the postprandial monitoring is very important also, because that is the one when it's maintained in patients, particularly in GDM patients. The glycemic control it will tell you the glycemic control when you do a proper postprandial monitoring. And because then we know that when you control her sugars very well, there's going to be a lower risk of preeclampsia. So the targets which have been taken up by American College and the American Diabetic Association is the fasting target is 70 to 95 as far as a type 1 and type 2 diabetes is concerned. For GDM, it's less than 90. The 1-hour value, which is the target, is 110 to 140 for type 1 and 2 diabetes, and it's less than 140 for a GDM patient. And the 2-hour level, which you need to aim for in a type 1 and type 2 diabetic, is 100 to 120. And which is GDM, the target is less than 120. And all that is milligram in DL. And regarding HbA1c, it can be measured in a patient with pre-existing diabetes and she has become pregnant. And because that will tell you the level of risk she has got during a pregnancy. And we have to remember that the level of risk will increase when the HbA1c level is more than 6.5 in a patient with a pre-existing diabetic condition. And suppose the patient has been diagnosed with gestational diabetes in the first trimester of pregnancy, you can do a HbA1c level, because that will tell us like whether she was actually a pre-existing type 2 diabetic and she was missed in the preconceptional period. But please do not routinely use HbA1c level monitoring for patients with GDM or pre-existing type 2 diabetes to check for her glucose control in the 2nd and 3rd trimesters of pregnancy, because the hemodilution which happens in pregnancy is going to skew the results. The goals of monitoring is to reduce the risk of serious short and long-term complications in the patient. And to achieve this goal, both the patients and the healthcare providers will need to monitor glucose levels regularly. but the self monitoring of blood glucose and HbA1c monitoring may not provide a complete picture of changes which are happening in the patient. And that's because they don't account for all the glycemic variability, because the sugar levels can be varying every minute and that cannot be picked up with a 7-point testing or a HbA1c testing. And the main disadvantage with HbA1c is it provides only a 90-day average. And even though it's considered the standard of care, it cannot pick up areas of hypoglycemia and hyperglycemic episodes in the patient, and it's not revealed also. And the fluctuations which happen in the glucose level throughout the day and night are quite unknown. Regarding self-monitoring of blood glucose, it will provide information about glucose levels for only points in time. But even when testing for 6 times a day, you can still miss hypoglycemia and hyperglycemia. And testing in the night is actually impractical. You cannot expect a pregnant patient to get up in the night and monitor herself. And that's why there's advancing technology for glucose monitoring, which can be utilized in any patient with hyperglycemia and pregnancy. But the affordability problem is there, but can be utilized, particularly in type 1 diabetes, where optimum control is needed for a good outcome for the mother and the baby. And this is continuous glucose monitoring. And it is based on the concept of flash glucose monitoring. It's called the FGM concept. There's a sensor which you can be worn for 14 days. There is no finger stick calibration required. A quick scan of the reader over the sensor will collect and display the glucose data. And the standard NFC wireless protocols are used there. The sensor will automatically measure, capture, and store the glucose data. And there's a color touchscreen reader. So you have all the information in the screen when you're using a continuous glucose monitoring. It will provide a lot of glucose data, but the problem with this is there will be multiple reports and it will be very difficult to interpret and gain insight by a single physician. There's also high startup cost for this monitoring system, and only one patient can use one device. Products are difficult to use, require cleaning and disinfection, as well as a detailed patient training and counseling is crucial. And that's why the ambulatory glucose profile has come, AGP. It is a visual report that will collapse all the glucose readings from several days or weeks as if they occurred in a single 24-hour period, making it very easy to visualize the glycemic patterns. AGP graph will typically will be built from glucose readings, which are ideally taken for 14 days. The key benefits of this 14-day AGP graph is it will help us to assess and fine-tune therapy. The information in the graph is presented in a very simplified way that will make it easy for understanding of the patients. And it will also provide a link between the day-to-day behavior and the glucose level in the patient. And it will provide more data than a self-monitoring of blood glucose. It will be very easy to build a comprehensive graph, and that will provide more information about the glucose variability and the episodes of hypo and hyperglycemia, which may remain undetected in the conventional monitoring tools. And it is a visual report that will collapse all the glucose readings as if they occurred in a 24-hour period. And that will be easier, it will help to easier visualization of the glycemic patterns. It will also provide a visual representation of the glycemic targets which are needed, the glucose variability, and the patterns of hypo and hyperglycemia. And that's why the monitoring tools have moved from just checking the patient's sugar once in a while, and then it has moved to where the patient's HbA1c was added to the monitoring system, and then we went on to the ambulatory glucose profile. But there's something new which has come in after 2020, and that is time in range. Because we know for the management of diabetes, monitoring is very, very crucial along with lifestyle management and pharmacological therapy. So how are we moved from ambulatory glucose profile to a combination with time in range? We know that AGP has been a path-breaking tool because it will reveal glucose trends and helps to manage hypos, hypers, and drug dosing, and has made diet management also much better. It has also reduced the risk of complications, but as I said, the challenges remain. It has increased the workload of healthcare providers as they move from self-monitoring of blood glucose. And it can be difficult to understand for some consumers and the healthcare providers. And sometimes too much of data which is given can turn off some patients' diabetes from monitoring themselves. And that's why time in range is very, very important. And that is an advancement of AGP. In time in range, it is a standard measurement in diabetes management. It will track the amount of time a patient's glucose is in their target range. And the standard range which is taken for TIR is 70 to 180 milligram per DL. And spending more time in range means that the patient will have lesser short and long-term complications, because you know that when she's managing her blood sugars within that particular range, the complications are going to reduce. The characteristics of TIR is the percentage of readings and time per day within the target glucose range will be shown in the graph. It can be measured by any CGM device as a percentage per hour, and it's very, very easy to comment on and monitor. But still, there's no international consensus till 2019. But now some consensus come as far as the usage of TIR in hyperglycemia and pregnancy. And regarding the targets in CGM, it should be based on the individual circumstances, preferences, and needs, because she can be any type of diabetic, but you have to put the target range based on what level she needs to be in the target level when she's managing her glucose levels. So the target range, if you keep it as 63 to 140, which we usually keep for pregnant patients, the patient's TIR should be around 70%. That is, most of our glucose levels should be in that target range of 63 to 140, and at least 70% should be in that target level. And she can have a target below range, that is, hypoglycemia is acceptable up to 4%, but below that it is not acceptable. And the time above range should be less than 25%. That is, having a normoglycemia should be, the patient should have those episodes at least 70%. 25% acceptability is there for above 25%, for above range. But below range can never be cannot be more than 5%. That means hypoglycemic episodes are not accepted in the management of diabetes. So this is the target which is kept for pregnancy. And suppose she's in type 1 diabetes, as I said, the target range is kept at 63 to 140. The readings per day, the below target level, that is going for a hypoglycemia, should be only less, should never be less than 4%. Should be above that range. And the other problem is, if she's going to have above range, it cannot go beyond 25%. The target range which she needs to maintain is around 70%. And pregnancy type 2 and GDM patients, it will be the same target level is kept, and the same target ranges is kept, and above target level which they kept there is 140 milligram per DL. And it has been concluded that when you use this, the time in ranges which can be within the target range, below the target range, or above the range, they're quite appropriate and useful as a clinical target and outcome measurements, and they complement HbA1c for a wide range of people with diabetes. And the target levels should be considered as an integral component of CGM data analysis and day-to-day treatment decision-making. That is what the consensus is. But the evolution always has not been very easy. It has evolved over a period of time. So we have moved from just finger stick testing, we moved on to CGM readings. And because of CGM gave too much of data, the interpretation was so difficult. And then the AGP came, that's the ambulatory glucose profile, which collapsed everything into a single graph. And it told you like how much the readings were in the last 15 days. And then TIR showed that whether the patient is keeping her blood glucose levels within the target, which is acceptable, or she's having more of hyperglycemia or hypoglycemic episodes. And there was a study in 2017, which was published in Lancet, which is called as a concept trial, and that is continuous glucose monitoring in pregnant women with type 1 diabetes trial. And they used, one group used CGM in addition to standard care. And it included optimization of pre and postprandial glucose target levels. And it was compared to a group which did not receive CGM, but just only standard care in a patient who's got type 1 diabetes. And it demonstrated the value of CGM in showing an improvement in HbA1c without an increase in hypoglycemia. And there was a reduction in large for gestational age births, length of stay in the hospital, and neonatal hypoglycemic episodes. And when you want to compare mean blood glucose testing versus CGM, there was a cohort study which evaluated the glycemic variables, and they said the association of large for gestational age births was found when there was a greater association when the time in range was above the range. So when the target levels were more in those patients, it just crossed those target levels, she had a higher chance of developing a large for gestational age. And that worked comparably well with CGM compared to MBG, mean blood glucose monitoring. What about the comparison with HbA1c? CGM reported mean blood glucose was found to be superior to the use of estimated HbA1c, given that the changes of HbA1c that occur in pregnancy are quite variable. And the American Diabetic Association in 2023 came out with this statement. If you can use it in addition to traditional blood glucose monitoring to target pre and postprandial target levels. And when you use real-time CGM, it can reduce macrosomia and neonatal hypoglycemia. I'm finishing in a minute. Complicated by type 1 diabetes, but please do not use CGM alone as a substitute for blood glucose monitoring to achieve a glycemic target. You need to use it in addition to your traditional monitoring, but do not use it alone. That is a statement by ADA in 2023. And they have said you can use CGM time in range for assessing the glycemic outcomes in type 1 diabetes, but it did not provide an actionable data to address fasting and postprandial hypoglycemia or hyperglycemia. And the cost is also offset by the cost is quite more, but in a type 1 diabetes, it's worthwhile using it because it will improve the maternal and neonatal outcomes. But there is insufficient data for usage of CGM in type 2 diabetes or a patient with GTM. Thank you so much for a very, very patient hearing. Thank you.
Thank you so much, Dr. Charmila. And you have given us such an insight about all the various ways we can do to measure the blood glucose levels. And I can say one thing, that with the various methodologies for measuring the blood glucose levels, we all are now forearmed and forewarned actually in our management for hyperglycemia and pregnancy. Thank you for such a wonderful talk, Charmila.
Thank you. Thank you, ma'am. Thank you.
And Poonam has now come. So Poonam, you take over the last session.
Madam, any interaction can happen in the chat box, madam. Otherwise,
Yeah,
we will not
yeah.
run. We'll be late in our this. Thank you.
Yes, I think we should go ahead. Lovely talk,
Yeah,
Charmila.
Poonam,
Yeah.
Thank you.
I
Poonam.
had
start with
already
Dr.
introduced Dr. Vidya Dhobi.
Vidya.
Yeah.
Yeah,
Yeah, you
Thank
can
you.
start your talk.
Sorry.
Yeah, you give the conclusion talks with Dr. Vidya.
Yeah. Thank you very much. Can I share my slides?
Yeah, I have praised you a lot already, Vidya. You can go ahead with your talk.
Yeah. I know. Yeah. Hope everyone is able to see my slides. And at the outset, I must thank ICOG office bearers, and Foxy office bearers, Dr. Sunita Tandulwadkar, as well as Dr. Parag Biniwale, Dr. Sarita, and all the brains behind this very useful medical disorders in pregnancy webinars. And there, I think more than 500 delegates have joined. So my topic is hyperglycemia in pregnancy, medical nutrition therapy. And we all know that this is the cornerstone for any treatment you take up for any gestational diabetic or diabetes in pregnancy. Always we talk of nutrition. I will not go into the definition and overview because already those things have been covered. I just want to start with the management issues of hyperglycemia in pregnancy. One is most important is the patient education. Second is medical nutrition therapy. And once we see that the medical nutrition therapy fails, we enter into the pharmacological therapy. So what is medical nutrition therapy? It involves the carbohydrate controlled balanced meal plan, which promotes, one is optimal nutrition for the maternal and fetal health. And second is the adequate energy, which is very, very essential for the appropriate gestational weight gain. And achievement and the maintenance of normoglycemia is very, very important. Also, we have to avoid ketosis and we have to minimize the insulin requirement. So even though the patient is on pharmacotherapy, we have to see that she is properly educated about this medical nutrition therapy. Now, whenever we are managing GDM and we are putting her on medical nutrition therapy, after 2 weeks, you have to again get it the postprandial plasma glucose has to be done. If it is less than 120, continue medical nutrition therapy. Then again, you have to monitor 2 hours postprandial plasma glucose up to 28 weeks, once in 2 weeks, after 28 weeks, once in a week. And if it is not controlled, if it is more than 120 milligram per deciliter, you have to start insulin therapy. After you put her on insulin or any pharmacotherapy, you have to monitor again fasting as well as 2 hour
postprandial plasma glucose. Already Charmila has elaborately told what are the advances in the various investigations and how various artificial intelligence also has come in the monitoring of this plasma glucose. Now, why diet is important in managing GDM? It helps in managing blood sugar. That is one thing. Also, it provides the nutrients. Second thing, I am again telling this slide, I have again incorporated. And also very important is it manages appropriate weight gain as well as the fetal weight gain. So how we have to judge the efficacy? When the patient is receiving this medical nutrition therapy, fewer patients require insulin therapy. It decreases HbA1c, lowers the serious perinatal complications amongst the infants. That is, it lowers the perinatal mortality, lowers the percentage of large for gestational age, and less macrosomia. As per the ICMR guidelines, for an average weight gain of 10 to 12 kg, an addition of 350 kilocalories above the adult requirement is recommended during second and third trimester. So we should know the pre-pregnancy weight, what is normal weight, what is underweight, overweight, obese, and obesity classification. And once you record the BMI, you have to watch for a total weight gain in that pregnancy. So this chart helps us how to we have to monitor the weight gain. So how many calories does one need? It all depends on the gender, her age. Overall, it is sedentary, and the physical activity is very important, and her BMI. These are all things required to know and calculate the calories. So 30 kilocalories per kg current weight per day in a pregnant woman whose BMI is between 22 to 25, 24 kilocalories for the current weight per day in overweight pregnant woman, that is 26 to 29, and 12 to 15 kilocalories in morbidly obese pregnant woman when the BMI is more than 30, and 40 kilocalories per kg in pregnant woman whose is underweight, that is less than 22. So these calorie distribution, there are variable opinions, and most programs, they suggest 3 meals and 3 snacks. However, in overweight and obese patient, the snacks are often eliminated. So in breakfast, the breakfast meal should be very small, approximately 10% of the total calories to help maintain the postprandial euglycemia. Carbohydrate intake at breakfast is also limited since insulin resistance is greatest in the morning because of the cortisol. And lunch, 30% of the total calories, dinner, 30% of the calories. So this is how the distribution is done. Snacks, whatever the leftover calories that can be adjusted, that is approximately 30% of the total calories are distributed as needed as snacks. So this is how the calculation of the adult energy requirement is done. That is, energy requirement, kilocalories per day is basal metabolic rate into physical activity level. Basal metabolic rate for the adult female, that is calculated as 14 into body weight per, that is in kg plus 471. And basal metabolic rate for the adult females, that is the age group between 30 to 60, is 8.3 into body weight plus 788. So pre-pregnancy body weight should be taken into consideration when calculating this requirement. Now, this is one sample example which we can take up, that if the patient's weight is, patient is 28 years, she is a sedentary active pregnant woman, sedentary, not active, pregnant woman in second trimester with height 153 and her current weight is 60. So her pre-pregnancy weight is 54. So we have to calculate according to her BMI should be calculated, and her pre-pregnancy weight has to be taken, her BMI, and it is divided by 1.53. So her BMI is in normal range. So then you have to calculate basal metabolic rate, and that with this formula, it comes around 1213 kilocalories. And we have to also identify the physical activity level. It is 1.53 for the sedentary level. So this simple, you can take a picture and you can just calculate whatever the patient comes in your clinic, that can be, you can calculate and keep and tell her how much calories she has to eat. let us learn what is right nutrition. Though this calorie distribution, if you take according to the American Dietetic Association, that recommends the composition of diet for the woman in GDM is around 25% protein, 25% of fat, and 50% of the carbohydrates. But we have got a beautiful GDM plate that I will show later. Now, this carbohydrate requirement for GDM, total carbohydrate intake should be 55 to 60% of the total calories for the normal pregnant woman. And for women with GDM, the focus is to restrict this carbohydrate intake to 55 to 55%. So 5% reduction, and focus should be to give, very important is we have to give the complex carbohydrates and avoid simple carbohydrates. Now, why carbohydrate counting is very important? Because the food change into blood glucose. So very fast the carbohydrate is changed into the blood glucose, like between 15 to 2 hours, up to 100% of the carbohydrates changes, means it increases the blood glucose. Whereas proteins and fats, they take long time, like 3 to 5 hours. And fats take very long time to change into blood glucose if required. Now, counting carbohydrate is very important. Carbohydrate foods have greatest effect on the blood glucose, and it is helpful to plan meals by balancing these carbohydrate food at each meal. This helps to maintain the blood glucose levels within the target range, and thus we can check how many carbohydrates are eaten at each meal by recording the carbohydrate grams or carbohydrate choices on a food record. So 15 grams of carbohydrate, you take it as a one carbohydrate choice. Therefore, 30 grams of carbohydrate, two choices. For 45 grams, three choices. So complex carbohydrates with a lower glycemic index are preferred. So they are very well tolerated at breakfast, and they are at other meals. As I told, there are increased levels of cortisol and growth hormones at the breakfast. So initial food plan may have approximately 30 grams of carbohydrate at breakfast, and to satisfy hunger, protein foods can be added because they do not affect blood glucose levels. So protein and carbohydrate combination can be given. They are also a very important source of energy, like vitamins, minerals, and fibers, and that also affects the postprandial blood glucose levels. So controlling total amount of carbohydrates, distribution of carbohydrates, overall meals and snacks is very, very important. So this is how you can make a chart. Breakfast 4 servings, snacks 2 servings, lunch 4 servings, snacks again 2 servings, and dinner 4 servings, and that too complex carbohydrates. And you have to introduce various food groups. They were from these carbohydrates, not only from starchy foods, but also it comes from fruits and fruit juices, milk and yogurts, beans, vegetables. All these contain some form of carbohydrates. Not that vegetable doesn't contain carbohydrates at all. They also have the starches. The complex carbohydrates also have should be preferred, and you should know what are the complex carbohydrates, like oats, bajra, jawar. These are the millets. These are the complex carbohydrates. And simple carbohydrates, we all know that cakes, puddings, sweet biscuits, pastry, all those white maidas and naans, these are all simple carbohydrates. So these are to be incorporated. Healthy whole grain should be taken rather than the refined grains. So all the refined grains should be replaced by the healthy grains like brown rice and whole, and a mixture of various rajgira, atta mix. They are available in the market very well. Now, so one grain exchange is equal to one fruit exchange is equal to one milk exchange. This 15 gram exchange you can teach your patients. So carbohydrate counting also should be taught, that one exchange is equal to 15 grams carb. May also contain also proteins also. So these carbohydrates can have this combination, and you can tell them about the combinations there. So this is how you can teach a carbohydrate exchange. This picture you can, because there are many cravings for these pregnant women. So if she takes one small gulab jam, she can eat sometimes, but she can again count about the calories and what she is on what, because these will immediately increase her blood glucose level. So any food, it shows 15 grams carb exchange you have to teach her. And the spoons also. Spoons, they can use various measuring spoons to know what is the exact grams of carbohydrate she's eating. So these are the different meals you can tell her, like 1 cup of upma, 1 cup of curds, which will have the probiotics and prebiotics. Also, the breakfast can contain roti, dal, cauliflower, and half of the exchange of carbohydrate. So these are the various pictorial things you can show to the patient on whatever she can eat. Now, choosing the fruits for gestational diabetic patient, or you have to choose fruits with the low glycemic index, like apple, pear, orange, apricot, strawberries, and peaches. And you should avoid mango, banana, chiku, and kiwi. Now, what is glycemic index? It is a figure which is representing the relative ability of carbohydrate food to increase the level of glucose in blood. So there are low GI foods, and medium GI foods and high GI foods. You can classify food according to their glycemic index, and you have to offer the diet with low glycemic index, which is rich in fiber, and high fiber definitely improves the glucose tolerance. So this is why it is important, because high GI food, that they are digested and absorbed quickly, it elevates the blood sugar levels very high. And low GI foods digest and absorb slowly and maintains the blood glucose levels. So these are various foods which have low GI, like 2 or more servings of fruits and more dals and legumes, and all high glycemic index rices. Rice means polished rice and all should be then replaced by boiled rice or organic rice varieties. Now, what about fat requirements and other sources? Fat intake, saturated fat intake, like ghee, butter, coconut oil should be less than 10% of the total calories. Good fats like omega-3 fatty acids can be got from the nuts and seeds. And fats can be reduced from the diet by less frying and all the things. And you should always do not eat much biscuits. Even Marie biscuit have got maida and other things. They always say that they advertise also, but they are not good for any pregnant woman who is having gestational diabetes. Using lean meat like fish and chicken in place of red meat such as mutton should be advised to these patients. So you have to choose the healthy fats. There are various, you can see the signals. On the left side is a green, and in the middle is a yellow, and the right side is a red. So red side, these are the signals you should teach your patients again. You have to take the oils which is having PUFA fats and MUFA fats. So these are good for the health. Now, proteins are additional 23 grams of proteins you always advise, and there are vegetarian sources of proteins which can these pregnant patients can eat, like soya flour, paneer, yogurt, various types of lentils and dals, and seeds also contains very good amount of proteins. Now, protein requirements, extra 23 grams of proteins and 1.5 kg per body weight per day. 1 minute more, I'll just complete. So protein intake should be 20-25% of the total calories. So these women should also get the high fiber diet, and all fruits and non-starchy vegetables, nuts and seeds, and seeds like fenugreek seeds, that methi is very good in these diabetic patients, and flax seeds also, which contains lot of antioxidants. So eat high fiber food. And this is a simple diet plan which you can offer to this pregnant woman. Choose more of a medium and low GI food. And these are the various food choices you can offer to these patients. I just want to have a comment on the diet-gut microbiota interactions at gestational diabetes mellitus. There are various studies which are published that now there is a role of gut microbiota and a role of prebiotics and probiotics in gestational diabetes. These are the 5 actions for the maternal nutrition services in your antenatal care OPDs, and you have to put this chart, and you can classify the nutritional risk. If she's obese or thin or underweight, you have to advise accordingly. And this nutrition therapy has got various calories, how calorie count, you know how much calories the woman requires, and according accordingly. You should always target the sugar levels. If the patient is on MNT, not that you should not check her blood sugars. So you have to, after 2 weeks, definitely you should check. And your target should be before breakfast 60 to 90, before lunch and dinner 60 to 105, and after meals less than 120. These are the targets. And if insulin therapy, you have to tell about her diet. Have small, frequent, low carbohydrate meals. Meal has to be planned according to the dosage of insulin. Keep sugar candy or a banana handy if she experiences hypoglycemia. Hypoglycemia symptoms should be told to her, and monitoring sugar level is very, very important. And this plate I wanted to show you that this plate is very important. Half vegetables, 1/4 protein and 1/4 starch. And this handy portion you should always explain to her. So these are the food choices you can make, and also exercise is very important. Incorporate FIGO nutrition checklist, and this is a summary of dietary recommendations. What you should tell about to the patient of this hyperglycemia in pregnancy in patients. So energy, carbohydrates, proteins, fats, folic acid is very important, vitamin D, calcium, iron, and probiotics. It is complete the dietary recommendation. And also you have to educate the pregnant woman, as well as GDM card is there, and these are the sample menus which are available on NIN website, 1800, 2000, 2200, 2400. These are my references, and I'm extremely thankful to all the team, Dr. Ranjana Khannan, today's coordinators, Dr. Komal Chauhan, Dr. Jairani, and especially my thanks to Dr. Charmila, who brought in here for this talk on nutrition in pregnancy. Thank you very much. Thank you, everyone, and thank you all the delegates. Thank you.
Thank you, Dr. Vidya. The talk was very enlightening. And I think when we don't have time, then at least we can have some dietitian with us who can help with the patients. And these all charts, etc., which you have given, that are very important.
Thank you,
to
Dr.
put
Poonam.
in
Thank you.
our
Thank you very
OPDs.
much. Thank you.
And I'm
Thank
so
you.
sorry for joining late because got stuck in OT. So that is why.
I know.
Thanks to ICOG for having me here today.
Yes,
Thank
yes,
you,
yes,
ma'am.
yes.
Thank you.
Thank you very
Thank you.
much. Thank you.
Thank you, madam. Thank you so much. And we are moving on to the next session, the second session. I have the great pleasure and honor welcoming and introducing Dr. Vinita Singh. Madam is the Associate Professor in the Department of OBGYN Partner, and she is the consultant of the Care Hospital Agri Center. She is the East Zone Coordinator for FOXI and the Governing Council member of ICOG and FOXI. And she is the President of the Partner OBGYN Society 21-22. We welcome you, madam, to chair this session. And we have with us Dr. Kiran Pandey. Madam is the chairperson of the Medical Education Committee, FOXI, and she is the former HOD in the Department of OBGYN from the GSVM Medical College, Kanpur. And she is the peer reviewer of the Indian Journal of OBGYN 21-23, president of the Kanpur Menopause Society, president of the UPSSSB chapter of Oncology and Oncologist of India. She is the past president of Kanpur OBGYN Society and IMA member. We welcome you, chairpersons, for this session, and I hand over to the chairperson to introduce the speakers of the second session. Over to Dr. Vinita and
Ma'am, Vinita ma'am and Kiran madam not joined yet.
no, they said that they are joining. Just now I called up because Vinita,
Kiran madam,
yeah,
you-
Kiran
madam,
Kiran madam has joined. Yeah, Kiran madam has joined.
Kiran ma'am.
Unmute, ma'am,
She has joined. She
unmute.
has joined.
Please
She has joined.
unmute.
I was muted actually. I was trying to unmute myself. Sorry, yes, for the inconvenience. Actually, I was busy. Yes, please.
Ma'am, you can introduce the speaker, Dr. Sujata Mishra.
Hello. So
we can
thank
hear
you,
you.
Dr.
We can hear you.
Thank you, Dr. Jairani. It's my proud privilege to introduce Professor Dr. Sujata Mishra. She's a renowned gynecologist. She's Director, Postgraduate Institute of Medical Sciences Research at Odisha, Bhubaneswar. She's naturally in the Department of Obs Gynae. She's also President of Association of Obs and Gynecologists of Odisha. Vice President Foxy also. She has been in 2015 and she has been chairperson Medical Disorders Pregnancy Committee in 2019 and Secretary Association of Obs and Gynae, Odisha. She has many publications and very, as I said, a very good academician. So, Dr. Sujata Mishra, I welcome you for your talks.
So, good evening, everybody.
Good evening. Good evening.
I hope slides are visible, right? So that I proceed.
Yes, ma'am. Yes, ma'am.
Yeah, okay.
Slideshow.
Yeah, I'll do that. I'll do that. Yeah. So at the
Somebody has
outset,
to stop sharing. Yeah. Madam, now
yeah.
you can share, madam.
I have shared.
Slide
But
only.
you're seeing only your
No, I'm coming to it.
Yeah,
I
yeah,
haven't got to the
okay.
next one. I will go. Okay. So
Yeah, we can see it.
Yeah. So my regards, my best wishes to the ICOG chair, Dr. Parag Beniwala, to Secretary Dr. Sarita, to ICG chair elect Dr. Sheila. Thank you so much, Dr. Charmila, Dr. Komal, Dr. Jairani, for having me with you. It's a long time since I really came on in this topic in the ICOG. Thanks a ton. So when we talk about oral hypoglycemic agents, I wonder what you want me to tell about, because when you go through all the guidelines, the last word is, but insulin is the best, right? But nevertheless, because we've got this molecule and we are licensed to use it, there is a legality behind it. We will talk a little about that. So all said and done, the insulin is still the gold standard in management of type 2 diabetes in pregnancy and gestational diabetes. So why are we talking about OAD or OHA, whatever you want to call it? So probably the needs for multiple injections come down, so associated cost coming down, pain at the injection side, need for refrigeration, handling of the syringes, and all said and done, nobody wants to inject themselves for whatever reason. Hence, we do have a plethora of oral hypoglycemic drugs. Now, the issue is how many of these can be given in pregnancy. I would not like to talk on pharmacology and give a big lecture on pharmacology right now. So we will look at the basic drugs. One group is sulfonylurea. Glibenclamide is advocated. Biguanides, it's metformin. And then acarbose, which is a alpha glucosidase inhibitor. All of them have different modes of action. This is something we need to keep in mind. Glibenclamide stimulates insulin release from the beta cells. Metformin improves insulin resistance, and acarbose decreases the absorption of glucose at the intestinal level. Now, here I would like to tell all the listeners that every single lady who gets pregnant is programmed to become insulin resistant. It happens in everyone who becomes pregnant. But why do they all not become GDM? That's because we are further programmed to overcome this resistance. Only those who cannot overcome this physiological insulin resistance, they manifest as GDMs and then the need of insulin / OHA. So these are a couple of guidelines which I went through, and several more. There was this ADA guidelines 2025, the Foxy guidelines, the article in Jogi, then what NICE says, etc., etc., etc. And then I realized a whole lot of confusion, whole lot of controversies, and do we have any consensus is what I would like to tell towards the end. There is a lot of data, yet there's a paucity for long-term use, because not many offsprings have been followed for a long period as to what it does. So all said and done, it is still restricted, but one can use it in these cases. Which drugs can you use? Glibenclamide and metformin have been widely used and they have been endorsed. Now, why would we like to give oral anti-diabetic drugs? Because similar features exist both in type 2 diabetes patients who are not pregnant, right? And in GDM, both have insulin secretion issues and resistance abnormalities. There's a loss of the first phase of insulin secretion, and there's a striking lag time between the postprandial lysin glucose and significant insulin action in the peripheral sites. Now, these second generation sulfonylureas are rapid in onset and have a shorter duration of action and are said to be an ideal agent for treatment of GDM patients and early onset, early stages of type 2 diabetes. So before going on to using these drugs and how we need to monitor, I would just highlight a little on the ADA goals and glycemic goals. Of course, Dr. Charmila has done a fantastic thing of showing up all the values, etc. But nevertheless, now if you see, all these blood glucose monitoring systems have an evidence level of B. All of them have B. So I guess one can choose any of these. But in DIPSI, we all like to follow DIPSI and we look at 2 hours. Now A1C, actually A1C isn't advocated that strongly as it used to be done earlier because of hemodilution issues in later pregnancy, as Dr. Charmila pointed out. Now, what should the goal be? 6, 6.5, 7? What are we looking at? Well, the goal definitely should be less than 6. They further go on to say, okay, can be relaxed till 7, but no, we're looking at 6 to 6.5 max, and the level of evidence is B. Again, with insulin, all the level of evidences are in favor of insulin, but they say in some cases, it may be the preferred agent, which makes one think, if it's a preferred agent, preferred to what? Obviously to oral hypoglycemic agents. So this brings me to sulfonylurea. I would just tell you in very brief about it, the do's and the don'ts. It is glibenclamide or glyburide. Earlier, it was said that it does not cross the placenta, but now it's proved beyond doubt that it does cross the placenta, does stimulate the fetal pancreas to form more insulin, secrete more insulin. Hence, there are issues of macrosomia and increased neonatal abdominal circumference. Now, when we are looking at bringing down a number of diabetic patients by 2030, we are also looking at a progeny which is not, genetically programmed to become a metabolic syndrome case. If it's a, get my point? So while we are trying to bring down our incidences, the offsprings also have to be adequately controlled so that they don't add to the problems with metabolic syndrome and diabetes in later life and later years. So how would we give glyburide, the available, or glibenclamide, the same thing, 2.5 milligram tablets up to a max of 20 milligram per day. The efficacy is said to be similar to insulin. Now, whether you give this or you give metformin, remember, the key is to improve the glycemic status, not whether we are injecting or we're giving oral. So our justification has to be very rationalized. If needed, you can increase by 2.5 milligram per week in increments and switch to a max of 20 milligram. Beyond that, please look at other things to do. Look at some other drug, look at giving insulin. Now, this is something which I've taken from the DIPSI set of slides, where Anjalakshmi et al. Way back had reported that, in some women who received glibenclamide, there was no statistically significant difference between the two groups in relation to BMI, gestational weeks, mean birth weight, cord blood insulin levels, and both glibenclamide and insulin were equally effective in achieving good glycemic control. The Langer studies also said that. So in other randomized studies, what do we see? 80% of the subjects treated with oral agents or diet alone maintained the targeted blood glucose levels, but those in insulin did not maintain. Now, this does not mean that insulin is not good. It just means that they do not want to take insulin, hence the role of OHA in patients who can be given OHA. Now, what about metformin? Since metformin reverses insulin resistance in diabetics, type 2 diabetes, they also thought, why won't it do that in GDM also? Many studies were done, especially on PCOS cases who were on metformin. And at that point of time, in the early 2002, 3, 4, one was not discontinuing metformin, and it continued because they would think that, she could land up with an abortion or something. And in all those cases, they saw that there wasn't a great increase in the rate of malformation versus the treated and the untreated groups. Like, PCOS on metformin, getting pregnant and continuing, and those not on metformin who had conceived or metformin had been stopped. So this is what they said. Some more studies said, like, Gandhi P. et al., that the metformin group had a significantly lower incidence of macrosomia a significant reduction in the supplementary insulin required. So meaning to say, if when metformin instituted was not adequate to maintain the glycemic status, then insulin was supplemented. And that dose was less. And continuing metformin throughout pregnancy in women with PCOS also was seen to improve, but now it's not advocated. So over half of the metformin treated group were able to maintain the glycemic control only with oral hypoglycemic agents. And this was proved in this MIG trial. The only thing which happened with MIG trial, which was around 2009-10, was that as compared to insulin, somehow the degree of macrosomia was a little more. So while metformin does not cause hypoglycemia, it improves insulin sensitivity and is a good agent for use in obese patients with insulin resistance, and is also cheaper as compared to the injectable group. Now, it didn't stop there. They went a step further. Okay, if we are giving metformin and she appears to be okay, let's look at the children who were slightly macrosomic. They were seen at 2 years. So it was seen that in the metformin group, compared with the insulin group, the children had larger mid-upper arm circumferences and subscapular and biceps skin folds. But the total fat mass and percentage body were not very different. So obviously this needs a little bit more of follow-up. Now, metformin compared with insulin in treatment of pregnant women with overt diabetes, this also said that, they continue to receive metformin and only 43% required supplemental insulin. So they concluded saying that metformin should be considered, but where required, supplementation should not be stopped. Where necessary, you may stop that and go on to insulin. There is nothing do or don't kind of thing. So before these are recommended, the concern should be the increased rate of congenital anomalies, which is not so much in GDM cases. It's more to do with type 2 diabetes. The possible induction of fetal macrosomia due to direct stimulation of fetal pancreas, more with glibenclamide, and an occasional rate of hypoglycemia due to fetal hyperinsulinemia. So after the MIG trial, they went on to look at children 7 to 9 years of, those who were delivered from people in this trial. And it was seen in an Auckland cohort that they were heavier and had a higher waist to height ratio, which makes you think, what else do we need to look at so that we get some more apparently, normal children who would not have these BMI values. At 5 to 10 years, it was shown that the offspring had higher BMI, weight to height ratios, and increased waist circumference when it was seen used in pregnancy for PCOS, and then later on, even if they manifested at GDM, it was continued. This is about the follow-up of metformin. Yet another trial, the MITI Kids trial, said that there was no differences in anthropometric measurement of children at 24 months. So we have trials at 24 months, we have up till 2 years, we have up till 9 years. There were no congenital anomalies, but maybe the control wasn't as perfect as it could have been in some cases. So whether it is cost, comprehension, or cultural influences, all said and done, if there is some reason for potential growth restriction or acidosis in the setting of placental insufficiency, in cases of GDM, for instance, hypertension, preeclampsia, ultrasonic features of IUGR, FGR, we would say, please do not use oral antidiabetic drugs or oral hypoglycemic agents. They can be used otherwise. So what does Foxy say? Foxy says, when sugar levels cannot be controlled with NMT, start with metformin. If metformin is fine, it's fine. If it does not control, give insulin. It does not talk about glibenclamide at all. And of course, metformin should be started at 500 milligram, increase in 500, 500, and the max should be 2 to 2.5, 2000 to 2500 max, but it is 2000. Make sure that she does not have any renal issues before giving metformin. Now, ADA does not mention OHA at all. They just say nutrition, physical activity, and insulin. DIPSI 2024, yes, says, yes, you may use it, but insulin reigns over them. Our Foxy guidelines, as I told you, says metformin or insulin. ACOG says the treatment focuses on diet, exercise, and potentially medication, usually insulin, to maintain the blood glucose levels. So what do the current guidelines say? We can use metformin or glibenclamide, for a lower, when it's 140 to 160, MNT has failed, one can definitely try. You can use it. And counseling and documentation is essential. And what can be used? It's metformin or glibenclamide. So I conclude with 2 slides. Oral anti-diabetic drugs are non-invasive, cost-effective, patient-friendly, readily accepted by patients as compared to insulin injections. All 3 subsets that I spoke about have different mechanisms of action, and you're the best judge to decide. Evidence suggests that glibenclamide is as effective as insulin in maintaining the desired glycemic levels, but some cases fetal hypoglycemia has been noted. However, to achieve a target level of glycemic control, if not achieved with oral hypoglycemic agents, insulin should be given. Maybe in the near future, we will get several studies with appropriate sample size and power that will evaluate all these, and we will get combination therapies like glibenclamide and acarbose, glibenclamide and metformin. But till then, we are happy with glibenclamide and metformin. They can be considered as an alternative or add-on therapy, but they cannot replace insulin from its own position. So access to care is the key to development. Wake up to diabetes and look after our DDM patients. Thank you so much for a very patient listening.
Over to Chairperson, Dr. Kiran, Madam. Dr. Kiran, Madam. Madam is here.
I think Jairani, you can go ahead.
Sujata, excellent talk. So much. I think this is starting for your travel also, am I right? Sujata, excellent talk.
Thank you, Sheila.
Very
Good
nice,
to see you.
Yeah,
Good to
even
you.
I wanted to say, Sujata, listening to you after a long time.
Long time.
Long
Yes,
time.
Shobha.
Yes.
Shobha
Yes,
here.
yes,
Yeah,
yes.
Shobha here.
It
Yeah.
is a great pleasure to have Sujata Madam. I think we had a pleasure to
Correct.
meet in person in
Yes.
between.
It
Yeah,
was excellent talk,
Sujata, just
very
wanted to
crisp
know.
and very proper point-wise
Yes.
discussion of the different drugs, which is very, very clear message.
Correct.
Thank you.
किरण एक पूछना चाहती थी मैं इनसे कि
हाँ.
acarbose, some evidence has come up on it's very interesting actually that it gives good. Yeah.
Yeah. So can I? Do we have time, or we can talk later?
No, you can just
So
answer.
on acarbose, I will be sharing a paper with you, which we had done on acarbose, where we had compared acarbose to insulin borderline cases. So what we need to do is look at the weight, less than 60, more than 60. Less than 60, go up to maximum 50 milligram, 8 hourly, 150. More than 60, you start with 100 milligram, and it is definitely effective. And anyways, it works locally. So, these long-term effects are not there.
Yeah, even I heard that, some endocrinologists also saying that maybe the future holds acarbose.
I
So we must
will
look.
share that study with you.
Correct,
But the
correct.
only thing is,
Madam, we request that the discussion be happen in the chat box because we
Sure.
cannot
Yeah, Charmila.
cross the
Thank you,
time.
Charmila.
Yeah.
Thank
Please
you.
put the questions
Please
in the
go
chat
ahead.
box.
Yeah.
Thank you,
Thank you.
Dr. Jamila.
Thank you, ma'am. Thank you, ma'am.
Kiran, Madam, can you introduce Dr. Vicky Saxena?
Yes. Hello.
Kiran, please
Yes, ma'am, we can
continue.
hear you, ma'am.
Okay.
Yeah, you're
Okay.
audible. Please continue.
Okay. So it's again my privilege to introduce Dr. Vicky Saxena. She is a winner of 34 gold medals in national and international conferences. Such a beautiful CV to start with. Editor of 11 books, published more than 250 articles and chapters, more than 450 invited talks, chairperson of AOGD Infertility Reproductive Endocrinology Committee, national coordinator of Foxine Medical Disorders, convener of many societies, SIG, Early Pregnancy and Fertility Society, again national coordinator in so many, such a beautiful CV, I think, very impressive. And she's expert
We are
also in
waiting to
many
hear a
groups.
talk.
Yeah. I know I don't want to take cut short your time. So it would be really our pleasure and privilege to listen to you, Dr. Vicky.
Thank you. Thank you so much, ma'am. Is my slide visible?
Yes, make it full screen.
Can I make it full screen?
Yes.
So I think we've had a very focused, a beautiful series of talks on hyperglycemia and pregnancy. And now, after covering oral anti-diabetic agents and MNT, we come to insulin therapy, which is, I think, most of the gynecologists are really worried in starting insulin, and we are mostly starting on metformin. So I'll try to make it very simple. We have already talked about the glycemic targets. If the fasting is more than, fasting or pre-meal is more than 90, 1 hour we are generally not doing. If 2 hours after meal is more than 120, or nocturnal hyperglycemia, that is more than 60 is there. And during labor, if the blood sugars are more than 72 to 126, then we say that the woman may need some type of pharmacotherapy to aim for a birth weight of 2.5 to 3 kgs. And MNT, as Dr. Thobi has so nicely enumerated all the nitty-gritties about it, that is the first line. And if the patient is not able to maintain her target glucose levels 2 weeks in the second trimester, and please remember, it is only 1 week in the third trimester. If she is not able to get the target levels during this time, then it is time to start with pharmacotherapy. So now comes the question, should it be insulin or the easily available and easy to ingest oral antidiabetic agent, which Dr. Sujata has just enumerated. So insulin, we know, is the gold standard because it does not cross the placenta. It is not going to go to the fetus, and it is time tested and the efficacy is proven. So before starting any treatment with insulin, it is very important to explain the importance of achieving normoglycemia to avoid short-term and long-term fetal-maternal complications. It's important to tell the patient that the insulin resistance, it is minimum in the first trimester. In fact, the insulin sensitivity increases in the first trimester, but as the glucogenic hormones, the HPL, estrogen, progestogens increase with the development of the placenta, the requirement of insulin will increase. So it has to be, the patient has to be told that it is going to have far-reaching effects on the mother and the fetus, and that is why monitoring is required, how to treat, how to give the injections, the injection technique, where all she can give injections, because of course it's a stigma. People are very scared to take an injection in their body, and many of them think that you're injecting in the abdomen, so it may harm the baby. So all those things, along with, as Dr. Vidya said, carbohydrate counting needs to be told, and how patient and her relative, caretakers, husband or mother-in-law, whoever it is, has to be told about the treatment of hypoglycemia. Self-adjustment of insulin, if possible, should also be done. But there are certain indications when we do not wait for medical nutrition therapy and we start insulin straight away. We will not give a trial of MNT. MNT started along with insulin, and we will not wait for metformin therapy. Straight away, we will start insulin. These conditions are when the insulin resistance is a little high, that is moderate to severe. So if the fasting plasma glucose is more than 110, 1 hour plasma glucose is more than 140. If the GDM or hyperglycemia is establishing before 20 weeks of gestation, That means before the placental glucogenic hormones are being secreted, the patient already has insulin resistance. In patients with PCOS, as it was being discussed in the chat box. So in those patients, and if the period of gestation has exceeded 30 weeks, because by that time we feel that it is high time, maybe there is epigenetic changes in the baby, there is no time to waste for MNT to act for 1 week, 2 weeks, and then start insulin. So if the period of gestation is less than 20 weeks or more than 30 weeks, if we feel that the baby is going to develop macrosomia, AC is more than 75th percentile at the 29 to 33 weeks, if she's type 2 or type 1, that is overt diabetes, if she's in labor, if she has any of the end organ dysfunctions, if she's having ketoacidosis, whenever we are planning to give her a shot of corticosteroids for antenatal lung maturity, or she's having any medical complications, or she has a previous history where she had a sudden IUD, a stillbirth, or previous history of FGR, GTM, polyhydramnios, or in this pregnancy, she's having any of these complications, which mean that the insulin resistance is very high. Polyhydramnios, fetal growth retardation, and macrosomia, these three are supposed to mean a severe endocrine imbalance. In all these cases, straight away, we should go for insulin. So there is a little difference between GTM and pregestational diabetes or overt diabetes, which is both type 1 and type 2. In these patients who are already having pregestational diabetes, it is better to start on basal bolus insulin. So in type 1 diabetes, we continue with the insulin regimen because, of course, there is no insulin and we cannot give them any metformin. There is a fall in the requirement during first trimester, and then it starts increasing. It increases in the first trimester, it is 0.7 unit per kg, 0.8 in the late first trimester, then
Just a minute. I think somebody has paused the screen sharing.
Yeah.
Should I
Can we?
stop? Should I stop sharing and share again?
No, I don't know. Yeah, we can see you. Yeah, you can share again. That will be better.
Okay, I'll share again. Is it visible now?
Yes,
it's
it is
visible.
visible. It is visible. Yes.
Okay. So as the period of gestation increases, we can see it increases from 0.7 to 1 unit and 1.2 unit in the third trimester by about 35 weeks. In type 2 diabetes, if the patient is on any oral anti-diabetic agent, it is time to shift to insulin because the requirement of insulin in these patients is very high. It is higher than what is required in type 1 diabetes also. In first trimester, as we found that insulin sensitivity improves little bit, so the same dose as in pre-pregnancy period. In second trimester, the dose is increased by 33% and in third trimester by 40%. So, and in GTM, it is nearly half the requirement of what is required in the pre-gestational diabetes. So how to initiate and titrate insulin? This is very, very important. So the basic principle is that as soon as you diagnose a patient with DIPSI as GDM or any hyperglycemia in pregnancy, we need to admit the patient and get her 7-point profile. By 7-point, I mean fasting, pre-breakfast, 2 hours post-breakfast, before lunch, 2 hours post-lunch, before dinner, 2 hours post-dinner, and 2 a.m. also. So if the fasting is high, we need to give them an intermediate or long-acting insulin in the night, which will take care of the fasting. So this could be either NPH or Detamir or Digludec at night. If the pre-meal is high, then again NPH has to be started. If it is the post-meal which is high, either it is post-breakfast, post-lunch or post-dinner, we need to give them some short-acting insulin so that it is going to control the peak and it is not going to last for very long. And what is mixed-start insulin? It contains both mixture of short-acting and long-acting insulin. And just remember that 1 unit of insulin may be able to take care of 20 to 30 milligram per deciliter of blood sugar. It is not any steady fast or a fixed value, because it will depend on how much obesity the woman is having, hyperandrogenism, all those things will determine the value of insulin to be titrated. So this is a rough chart. You can take a picture if you want. And this is a very important slide. So here we can see that we were generally using regular insulin and NPH insulin, or Mixtard, which contained regular insulin and NPH insulin. But now we have insulin analogs. We have rapid acting insulin, the insulin Lispro and Aspart. These can be taken along with the meal, 1 to 15 minutes with the meal, and the action will last for 1 to 2 hours, and it will come down very quickly. This is the physiological. By 1.5 to 2 hours after eating anything, our blood sugar is maximum, and then it starts coming down. By 4 hours, it becomes normal. So the rapid acting insulin, the Lispro and Aspart, which are approved by FDA for use in pregnancy, glucine is not approved. So these are going to mimic the physiological peak, and the action will stop at 4 hours. Whereas, as you can see here, this regular insulin, the action is going to last for 8 hours. So at this time, between 4 to 8 hours, she may develop hypoglycemia. Our regular insulin has to be given half an hour or 1 hour before meals, and the action will come back, the value will come to nil by 6 to 8 hours. NPH insulin, which we are using in government institutes, the action will start in 1 to 3 hours, and it will last, as you can see, this NPH insulin, it will last for about 18 hours, 13 to 18. And now we have designer analog insulins, the Detamir and the Glucine. The good thing is that there is no peak. So the chances of patient going into hypoglycemia are very, very low. Now coming to the concept of basal insulin and bolus insulin. So basal insulins are those long-acting insulins which are going to maintain normoglycemia in the fasting state and in the pre-meal stage. These are NPH, Detamir, Degludec, and Glargine. If the patient is already on Glargine and she is maintaining her blood sugars, that can also be continued. And the bolus ones are which are going to take care of this postprandial peak. These are our conventional regular insulin and the Lispro and Aspart. So these are the sites: the anterior abdominal wall, anterior and lateral part of the thigh, the deltoid, where the injection can be given. It has to be rotated. Monitoring, I think, has been very nicely already told by Dr. Charmila. It can be done by venous sampling, plasma calibrated glucometers, and the new tool of continuous glucose monitoring. It has been now validated that point of care testing by glucometer has a sensitivity and specificity of 80 to 98% and is also recommended in the national guidelines and FIGOs also. So I was fortunate to do 2-3 theses on this continuous glucose monitoring, and we found it to be very, very important in measuring the glycemic variability and in finding out the hypoglycemia at the night time and hyperglycemia after meals. So this comes for about 4,500 rupees, and this was an older one. This is a small thing which is attached on the deltoid, on the upper arm, and this was the sensor. But the new ones now, you can take it directly on your mobile. You have to download an app and it will continuously, you just take it here, it will show you the graph. And it is very simple to comprehend. Even my uneducated patients coming to Lady Hardinge Medical College were able to monitor it. And this is how the time in range, as Dr. Charmila was saying, this is between 80 to 140, this gray zone. This patient developed severe hyperglycemia she was having. When we started her on insulin, she started vomiting. And this red area, you can see this is hypoglycemia. Even an uneducated person will be able to see this. And then she went into ketoacidosis. So it gives an average glucose, time in range, time below range in red, which is very dangerous, and time above range, as you can see here, this is in yellow. So it is very good and it comes for just 4,500 rupees, and you can use it for 2 weeks and see which meals are going to cause a big peak and how you can regulate your activity also. So best thing to do is 7-point profile. Once you get a normoglycemia by titrating the dose of insulin, but if that is not possible, you can do 4 tests, fasting, and then 3 postprandials, or you can do a staggering or rotating. Then you can do fasting, next day post breakfast, then post lunch and post dinner. It is very important to monitor because the dose of insulin is going to be titrated depending on the fluctuations. If the patient has some fever, if she has some infection, if she has some stress, all these things need to be looked up. If suddenly you see 1 or 2 values which are going haywire, you have to see if she's having any of these faulty lifestyle, she's not had enough food, or she has had a chola bhatura or some sweet in between. No need to change the dose before 48 to 72 hours. Okay, and if there is only a little bit of increase in blood glucose levels above target, tell her to split the meal or take a 15-minute walk. It is very important that we educate the patient and her caregiver that less than 70, I always write down on the ANC sheet, less than 70, less than 90, and less than 120. These are the target values before for hypoglycemia, fasting, and post-meal. Tell them about early symptoms: tremor, sweating, palpitation, hunger, easy fatigability, tingling. Then severe features are confusion, abnormal behavior, visual disturbances, and if so we need to tell them, I will be just finishing in a minute. So they should be well versed. 3 teaspoonful of glucose powder. If it is not available, then 6 teaspoonful of sugar in a glass of water, and then they should take them. Termination of pregnancy, I'll not talk about this. Target during intrapartum period is again 70 to 126. And if the woman is on insulin, blood glucose to be monitored early. And also we should be monitoring the ketone levels. And depending on this, we can either give her blood sugar, we can either control her on insulin infusion, or we can start a drip. If she is going to be taken for cesarean, she has to be kept nil perorally, omit the morning dose of insulin, send fasting blood glucose, serum electrolytes. Post-operatively, keep on doing blood sugars frequently to hourly, and ketones should also be monitored. And sliding scale can be used. These are the beautiful scales which are given in our national guidelines, and you can watch it from there. Just one very important message regarding the use of, as you can see, of pharmacotherapy in diabetes. All the recommendations say that insulin is the first line, but metformin is also recommended by our MOHFW, the latest GIPSY guidelines of 2023, and the NICE guidelines as first line. ACOG and ADSA, you can give it as second line, but tell the patients that it can cross the placenta, and long-term safety is not well established. Glyburide has gone into disrepute now because it has a high chance that the baby will develop macrosomia or neonatal hypoglycemia. So some of the guidelines have said that we should not use it. And this is a very, very important message. The national guidelines of UK, NICE, and the regulatory authority, that is the European Union, in 2022, they said that metformin can be used during pregnancy from conception to delivery if the healthcare professional feels it's appropriate. This is based on solid data. A lot of strong evidence has come up. And now I'm very happy to inform all of you that the CDSCO, the Drug Controller General of India, which is the regulatory authority, has also given permission. They have granted the permission of use of metformin during pregnancy. Now we are medico-legally also safe. And as the placenta comes out, the glucogenic hormones are gone. So GTM woman may not need any insulin. We can do fasting and PP for 1 to 3 days. Type 2 diabetes, the levels, the requirement can go back to the pre-pregnancy time. Overt diabetes type 1, the requirement will come back to come down by 20 to 40%. Metformin and glyburide may again be used during lactation. because they are secreted in negligible amount. To conclude, GTM gives a golden opportunity to correct the endocrine milieu to avoid the long and the short-term complications, not just to the mother, but also to the baby. Insulin is the gold standard. Metformin is also an excellent drug, can be used as a second line, but we still need to be a little careful about it, and it should be avoided, as Dr. Sujata has said, in patients who are having uteroplacental insufficiency, preeclampsia, and growth restriction. I thank you all for a very patient hearing, and these are some of my books. So thank you very much.
Over to Chairperson. Kiran, Madam.
Thank you, Dr. Pinky. It was once again, I will say I've heard you so many times, and every time I hear you, I realize that, and it's your concepts are so clear, and you make everyone else also very clear on the concepts. Insulin, of course, as you very rightly said, gynecologists and obstetricians are a little always hesitant to take it, but we have to, many times it is really required that we have to take this initiative, and that this specific knowledge of basics is very, very important. So wonderful lecture, and you cleared all the types of insulin and their actions have to where they the newer ones which are coming are definitely the ones which are more safe and designed actually for that, to take care of the mother and the fetus. So thank you once again.
Thank you.
For
Thank
a
you,
very wonderful lecture. Thank you, Peggy.
Ma'am, can you introduce Madam?
Oh, why not, Sita? It will be my pleasure. How are you, Dr. Sita? Doing
I'm
very
fine,
well?
thank you. So, I think just one line is enough. We'll start off with the.
I know, but at least some 1 or 2 lines are very important. And we do know all, but there are many persons in the audience who will like to know more about you. And we all know you're a renowned fetal medicine and consultant, and of course obstetrician. So we all are, and she is working at Apollo Multi-Speciality Hospital, and specifically that Fetal Medicine Institute in Calcutta. She's honorary Joint Secretary Bengal, chairperson Genetics and Fetal Medicine Committee. And she's also president of the Society of Fetal Medicine. I know there's so many webinars and every podcast, everything you are doing with the fetal medicine.
Thank you so much.
So many posts she has already held, and Dr. Sita is a very humble person with such a great knowledge. She's still one person who is always available at any time you can phone. So you feel very comfortable. Please go ahead with it.
Thank you, Ken. I'm sharing my screen. Thank you, Dr.
Yeah.
Kiran, Madam, my co-chairperson in Foxy, for those very kind words. And I'll just share my screen. Firstly, a big thank you to the Foxy leadership and the ICOG leadership, Dr. Parag Beniwale, Dr. Sarita, especially Dr. Charmila, Dr. Komal, for giving me this opportunity. And I have heard the talks yesterday. They were brilliant. And even today, thank you, Piki Madam, for a wonderful talk, and all the talks before that. So let me start on my topic, which is equally important and very concerning, because this is what we worry about all the time: fetal surveillance and hyperglycemia in pregnancy. And that's me for you. So thank you once again for this opportunity. So as we know, we've all been talking about diabetes in pregnancy, and we know that there's a risk of perinatal morbidity, mortality, and of course, congenital anomalies as well. And as we've heard earlier as well, you know, the type, we are seeing a lot of T2DMs and T1 type 1 diabetes mellitus. So the risk is highest when there is a type 1 or type 2, but it's not less with GDM as well, which we need to be aware of. And what we are seeing nowadays is that despite improved glycemic control and a declining rate of some of the rare anomalies that we used to see before, perinatal mortality, preterm birth, and large for gestational age with its accompanying complications like shoulder dystocia, and of course the dreaded complication of stillbirth still remain high, especially in pre-gestational, but also in GDM. Right? Now, this was a study done by BMJ where they looked at specifically GDM and adverse pregnancy outcomes in 2022, where they did a systematic review and meta-analysis looking at both maternal and neonatal outcomes. And when adjusted for co-founders, they said that yes, GDM was also significantly associated with a range of adverse pregnancy outcomes. And what they found that where insulin was not used in GDMs, and when adjusted for co-founders, these women had increased odds of cesarean delivery, preterm delivery, low 1-minute Apgar score, macrosomia also, and large for gestational age. And when insulin was used, the same thing also, but they had increased, more importantly, they had logically infant large for gestational age with RDS, neonatal jaundice, and more so requiring admission to the NICU. So generally, what are the problems we see with these women with diabetes? They tend to have increased risk of spontaneous miscarriages. Congenital anomalies still lurk there, and especially the GDMs, which we think they are actually GDMs, but they're actually pre-gestational. They get diagnosed early in the trimesters. So, if you do an HbA1c, we'll know that they were actually pre-gestational. Now, there are different growth trajectories in these women. If they have vasculopathy in type 2 DMs, then they are at a risk of fetal growth restriction. But if they are GDM or with poor controls, they tend to have large for gestational age and macrosomia to the range of 15 to 45%. So both are equally worrying and need to be monitored for. And with its, large for gestational age with hydramnios, they are at a risk of preterm birth. And even if they develop fetal growth restriction, they are at a risk of iatrogenic preterm birth. And of course, as I said earlier, stillbirth, which, we still aren't very clear as to how to sort of predict this and how to prevent it. And of course, there are neonatal issues of respiratory distress syndrome, neonatal jaundice, hypoglycemia, and admission to NICU. So with congenital malformations, there have been different studies, and they said that even with GDM, there is an increased rate of congenital malformations, and with insulin-treated GDM, but not in diet-treated GDM. And early fasting glycemic diagnostics that are done for GDM was associated with a significantly increased risk of congenital anomalies, especially cardiac malformations. Now, these are all for GDM, but when we talk about pre-gestational diabetes, yes, the risk goes higher with increasing HbA1c, but it's highest when it's more than around 9 or 10%. But whatever it is, we don't tend to recommend a termination of pregnancy, but you don't know, it's like fetal infections. All fetuses might not get affected or to cause a congenital malformation. So you have to screen these women, do a proper ultrasound scan, and only then. So just on the basis of HbA1c, do not terminate the pregnancy. And yes, the metformin, as it's being increasingly used, there is no risk of congenital abnormalities with oral anti-diabetic drugs. Insulin, nevertheless, to say it doesn't cross the placenta, so we are not worried. Yeah, so again, this was a study which showed that the risk of congenital malformations and maternal diabetes was in the range of 6 to 10%, and both were associated with increased major malformations. So again, my point to say is don't take GDMs lightly as well. What are the congenital malformations? Mainly the cardiac ones, like the ventricular septal defect, truncus arteriosus, transposition of great vessels, and in the late third trimester, you might see cardiac enlargement, which is basically fetus having a hypertrophic cardiac myopathy. In CNS, we can have this open neural tube defect, caudal regressial syndromes, which are rare nowadays. Even sydenomyelia, sometimes we get to see. Renal is hydronephrosis, and skeletal, very long back, I'd seen this patient who was a Bangladeshi patient, and she had come with one previous IUD, and she had focal femoral hypoplasia, where just the femurs are hypoplastic and they are not developed. They end up, and this is mainly because of very poor glycemic control, and that is one of very a barn door sort of a classical abnormality like open neural tube defect in diabetes. So what about fetal growth? Now, generally, when we talk about fetal growth, we talk about placenta and other issues. But in diabetes, there are different things that are working on this fetus for its growth, which is one is the genetic potential, of course, of the baby, the substrate availability that is there in these women, in these fetuses when the mother is diabetic, the endocrine regulations that are happening because of different controls with the drugs or insulin, the fat mass, which the environment that is there for the fetus, and also the fat-free mass, which is the genetic factors. So that is why you have to look at what causes these problems. And here they have shown that in fetuses of diabetic mothers, there's an accelerated growth, especially because of all these placental factors like growth hormones, which causes gluconeogenesis, lipogenesis, excessive anabolism in these fetus, causing hyperglycemia and hyperinsulinemia, which increases the insulin and causes fetal growth and neonatal macrosomia. But there are no clear thresholds for increased risk. And what is mainly seen is the increase in the subcutaneous fat, which is seen even without the macrosomia. So even if the baby overall weight might not be there, the increase in the subcutaneous fat is what predisposes these fetuses for problems. And they have said that the increase of blood sugar, like if you've seen that the lady, her sugar controls are not good, and there is an increase of more than 10 to 14 milligram percent or 14% rise, of a 10 milligram percent rise, there is almost 10 to 15% risk of these fetuses being large for gestational age. In fact, Harper has said that there is a continuous association of these high in sugar levels with accelerated fetal growth, and that is what we need to monitor. So there is something called a thin fat phenotype. As I said, both ways the baby can be affected. This was a study where they looked at almost 947,000 deliveries, and they said that the LGA prevalence was in the range of 26% with GDM and 10 compared to the non-GDM population. And more importantly, the GDM had disproportionate LGA. The distribution of fat was not proportionate, and that was causing more problems. And that's why they had the risk of birth trauma and hypoglycemia. So when it comes to the other side, they had low birth weight babies as well. There are higher incidence of SGA infants in women with GDM when the glucose levels were below 87, and especially when you have tight control. And these were the ones where they was associated with stillbirth. So stillbirth, they said the maternal blood glucose and of course BMI were the strongest associations. But when the fetuses were less than the 10th centile, there was a 6-fold higher risk of stillbirth. And obviously when they were more than the 95th centile, there was a 3-fold higher risk. So what you would think that macrosomic babies would be more at a higher risk, it's actually the ones which have the vasculopathy and growth restriction are at risk of stillbirth. And the risk is highest at term. Now, one thing you must understand that post macrosomia, once the baby has become macrosomic, then you tighten the glycemic control. That does not change the risk. The risk remains the same. So you have to do things before the baby becomes macrosomic, and that is what is the concern. So there are other concerns, obviously, with these women. There is risk of preeclampsia, so that is why there is a risk of growth restriction, birth trauma, instrumental delivery, all leading to increased risk of cesarean section and neonatal issues. So what can we do? We have to start right from preconception. Of course, that is the best way to look at glycemic control. So they start off the pregnancy with a good sugars. But if she comes in the first trimester, your look for fetuses is the first trimester becomes a window of opportunity where you screen for maternal problems and you look at it's an important landmark for fetal evaluation. We no longer look at just whether it is a singleton or twins. We look at other things, and we basically look at a morphology scan. We look, along with aneuploidies, which these women are at risk, especially if they are elderly. You look for structural defects, neural tube defects, growth restriction, as well as, not necessarily pick up growth restriction, but you screen for preeclampsia and these structural defects like encephalocele and stuff. Now, apart from the usual biomarkers that we use for predicting preeclampsia, there have been suggestions of other biomarkers which can predict diabetes, like especially first trimester insulin, uterine artery PIs, decreased PAPIC to some extent, and TN-alpha factor, but these are still in the range of research, and these are more accurate among obese women. Also, they have said that you should be screening them at 8 to 10 weeks, which is obviously practically may not be possible in our scenario. One must remember that when we do screening for structural defects in the first trimester, 100% you might detect only a few ones. There are a lot which still goes undetected. So you have to counsel the families at all, and you have to call them again maybe earlier at 16 weeks, especially when these women are obese and there is a bad window for ultrasound. It's difficult to use. So we generally use a transvaginal scan along with transabdominal to look for problems. So the point is that once you look at them at 13 weeks, you do not forget them until the anatomy scan at 20 weeks. These women generally would be called for an early anatomy scan. Ideally, you should be calling them at 16 weeks because the baby is slightly bigger and you can look at the structures more clearly. But yes, some of the brain, especially brain, because it evolves, you have to still have a detailed anatomic evaluation between 18 to 20 weeks with basic cardiac screening, fetal echo between 22 and 23 weeks, and then serial growth scans every 2 to 3 weeks from 28 weeks or whenever GDM is detected. And that would go on till delivery. And of course, whenever you do that, you will assess the growth velocity, expect estimated fetal weight, like a volume, and a growth scan will never be complete without a Dopplers. In these women, especially as I said, because of the fetuses might developing cardiac problems later on in pregnancy, it may be a good idea if the sugars are not well controlled to have a third trimester echo as well. Why do we monitor fetal growth? Because it tells you the reflection of glycemic control. It predicts you what the problems can be. It has implications for treatment. If we know that this baby is growth restricted or macrosomic, you need more control. Sometimes we realize only on the ultrasound that there is a problem. And of course, we can anticipate what the neonatal problems may be or anticipate adolescent metabolic issues. Like always in growth restriction, when we say we have to use growth charts and large for gestational ages, whenever the AC is above the 90th centile or when the estimated fetal weight is more than 4 kilos, that is macrosomia. But we all know beyond 3.8 kilos, the weight estimation becomes very, very unreliable and unpredictable. Of course, SGA would be less than 10 centile. So rather than looking at one figure, you have to look at the growth trends. And again, like in FGR, you have to see crossing centiles, which may not exceed the 95th centile, but if your baby has jumped from the 20th centile to the 80th centile, we know there is an ongoing problem and we might have to screen or, check the sugars again. So they follow two patterns. They have either they conform to the mean or they growth restrict or they have an accelerated fetal growth. And another important thing to remember is that these growth patterns, unlike the placental problems, the growth pattern starts after 28 weeks and it is confined to the abdominal circumference and subcutaneous fat, which I told you. What is fetal macrosomia is defined basically as the birth weight of more than 4 kilo. And as I said, it is more with obese diabetics because these women have an accelerated growth in the third trimester from 24 weeks with excess deposition of fat in the interscapular area and abdomen, which you can understand is the problem when they have shoulder dystocia. Prior, up until 24 weeks, the growth pattern is similar to the other fetuses. Beyond that is when they develop this accelerated growth pattern. And obviously, the risk is higher in postnatally as well. But as I said, ultrasound is not very sensitive in predicting fetal weight more than 4 kilos. Issues with fetal weight is because we look at crude composition of fat mass and free mass. There is a common formula derived from normal populations, so we cannot use this for these fetuses. As I said, in these fetuses, there is an altered body composition. So errors in fetal weight can be almost to the range of 25%. And obviously, it depends on technical lack of time lapse. And because when you do a scan at 36 weeks and then you deliver later, there has the gains, it almost gains about 50 gram daily. And then you don't know what the exact weight is when you're actually delivering the fetus. So what has come up is there is prediction models in FMF Fetal Medicine Foundation where you can get the risk of macrosomia, but again, it may be unreliable. Also, there is new ones is the fetal anterior abdominal wall thickness, which is simple and easily performed. And here, if you take a standard AC view, anything greater than 3.2 millimeters is considered abnormal. So all put this together is an abnormal adiposity composite where they look at the anterior abdominal wall thickness with thigh adiposity. And if you look at this, these two, they combine and they add it up. If anything, and there are nomograms for that, anything more than the 90th centile at 38 to 39 weeks will be abnormal, where the cutoff is 8.1 millimeter. And all this will be associated with the abnormal complications, right? Amniotic fluid usually is not a prognostic marker, but when we see polyhydramnios unexplained, the first thing you would check is whether the sugars are fine, and that is some of the times when we ask the woman to check her, and many of the times we get them diagnosed, just one more minute, diagnosed as diabetes mellitus. Stillbirth is a very important issue and usually results, the cause is hypoxia, acidemia, and myocardial dysfunction, which causes unexplained stillbirth. And the risk is, though high, in GDM, the absolute risk may be low. Now, predictors are very, very difficult. A significant proportion of stillbirths occur at more than 37 weeks, and stillbirth was associated with both, as I said, growth restriction as well as excessive fetal growth, with a stronger association in more severe LGA, large for gestation age cases. So as I said, predicting stillbirth is very difficult. You have to closely monitor them with abnormal growth patterns, do a fetal kick chart. Maybe you can do a twice weekly Dopplers with interval CTG if their glycemic control is poor, but not one has been proved to be effective. And yes, these women will definitely require continuous fetal monitoring in labor. Growth assessment is never complete without Dopplers, but you need to do Dopplers, but they're not very good in predicting stillbirth, especially in large for gestational age. It may be useful if there is associated growth restriction or small for gestational age, right? So this was a lady who had this typical growth patterns and she was delivered. You can see the graphs just shooting off the scores, and you know that this is a large for gestational age, not controlled because of diabetes. Different associations have given different guidelines regarding what we need to do, regarding GDM and pre-gestational diabetes mellitus. But the bulk of the literature says that in GDM pregnancies, when there is associated with delay in lung maturity, you don't need to deliver them prior to 39 weeks. If a pregnant woman with GDM is well controlled, you can go up until 39 weeks. But with poor blood sugar control, you have to take them between 37 to 38 weeks, right? And especially this is in GDM, and in pre-gestational diabetes, usually it's better to deliver them before 39 weeks. So the long-term concerns are there is a risk of twofold risk of these fetuses having obesity and diabetes mellitus and increased insulin resistance. So you have to make sure that the environment is better for them. So the key messages from here for fetal surveillance is it starts from the first trimester. You screen in the first trimester, you do an anomaly scan and fetal echo, serial growth estimations with Doppler evaluation from 28 weeks. Depending on the glycemic control, you can call them every 2 weeks or 4 weeks. NST from 36 weeks onwards. Overall, the prognosis is good if it's well controlled, but the best strategy is obviously predict and prevent, and this is what even the FOXY guidelines recommend. So we know that this is a slow motion disaster of obesity and GDM. So it's important to predict and prevent the large for gestational age macrosomia. It is important also to understand the story is not about birth weight, but about fetal programming. And this is a unique time in pregnancy where we can take this advantage and prevent this dreaded problem across generations. And that is why they have said focus on the fetus for the future, by using simple strategies to prevent this dreaded complication in the fetus. Thank you so much for your patient hearing.
It was a super talk, huh? Sita, very nice. I think very nicely you have sent. I think there are some questions for you in the chat box.
Yeah, I'll have a look.
Yeah, because we have
Running
now
late.
rush the
Yeah.
time. So I think we can move on to the next session.
Thank you so much. Thank you for the opportunity.
So we are moving to the next session. The session is actually a case-based scenario moderation, moderated by moderated Dr. Komal Chavan and Dr. Archila Batra, madam. This is actually a case-based scenarios, and we have with us 5 panelists: Dr. Sheba Marwa, Dr. Anju Turiya, Dr. Mini Nambutri, and Dr. Alpana Chetri, and Dr. Siddharth. So over to you, moderators, for moderating the case-based scenario discussion with the panelists.
So welcome everybody, and I think this was a really learning thing, which so many insights we have got from all the stalwarts and the esteemed speakers. And still we see the chat box full of all the, lot of questions and everything. And that is the idea, that we are now going to have a comprehensive panel discussion, which will be case based. So the understanding will be more clearer and the messages will be very important, because this will be a practical based message. And with me and Dr. Achla Batra, we know that yes, hyperglycemia is increasing. There is so many insights about testing, DIPSI, but what is actually happening at a lot of in the government sector also, Sheila Mane madam also said in the beginning that almost 20 to 30% of people are also in the government setup also are having they're being diagnosed as hyperglycemia in pregnancy. But the testing of DIPSI, probably the availability is not being followed. You know, they are going to the conventional methods like doing a fasting, postprandial, and diagnosis is getting delayed because some patients don't follow up at all. So we still have a lot to work on it. You know, lot of lacunae are there, and the maternal risk, the fetal risk. You know, Sita has so well said about the fetal problems which the mother will have, the maternal risk, the monitoring. I think everything is so nicely explained in this talks. And the idea behind this panel discussion is to make everything very, very simplified. And with me and Dr. Achla and all the esteemed panelists who have joined, we will try to take all the questions, whatever if the participants have, they can put it in the chat box. Dr. Anju, Dr. Alpana Chetri, Dr. Mini, Dr. Sudha, and Dr. Shiba. Welcome all of you. And Achla, we can start with the first case. Dr. Achla.
Okay, so this is second gravita. See, last was vaginal, baby weight 3,500. And while she was being routinely investigated, her DIPSI 75 glucose test showed a value of 175. Her height was 155, weight 72. Everything was normal. Fundal height was corresponding. Ultrasound report, what she had was that it is a single fetus. Fetal weight was 870. Now, first, I would like to know, Dr. Anju, how is DIPSI screening done? You know, it's very important. If it is not done properly, you may get false results and false positive.
Actually, DIPSI is one-step screening technique. This can be done in all the cases we are having in large numbers. So in that way, the patient doesn't have to be fasting. She just has to take 75 grams glucose in 1 glass of water in 10 to 15 minutes. And after that, we'll have the level that is, if the level is in DIPSI, more than, excuse me.
Can you all hear Anju? Because I cannot.
You cannot hear.
No, ma'am, there's some signal problem.
Your voice is breaking.
Yes, ma'am.
We can hear Anju, but speak a little louder.
Maybe keep your mic a little closer.
Okay. So after the stress, after that consumption of glucose, the test is done after 1 or 2 hours. And in this case, what else? This is probably GDM because it is at 26 weeks. She vomits. But if she vomits, 30 minutes consumption again after 2 hours. Okay.
I think, Anju, you have said very properly, but a lot of questions had come also in the chat box regarding that 75-gram glucose. You know, everybody was talking about, can we give the normal glucose, or what is the opinion of the panel?
Yeah. So, Dr. Anju, you want to answer it, or you want to answer in the chat box?
25 grams glucose itself only.
No,
and apart from
they don't have the sachets.
75
It
and
is a problem.
headrest glucose is not available, you know. It is
Yeah.
available. You can, but in case you can't get it, at least remove 5 spoons from the 100 gram and do it. You'll get some value, but best is, of course, with anhydrous. As such, 75-gram pack of normal glucose are not available, but anhydrous glucose, they are available.
Yes.
And the other technique can.
So, if she vomits within 30 minutes, then you have to do it again. After 30 minutes, the test is valid. Any other tests you know of? The people are doing various kind of tests. Everybody is not doing DIPSI.
There are WHO technique test also, in which the patient is fasting. Apart from this, there is an International Association of Diabetes Study Group guidelines. This is also being done. In this case, also fasting. In this case, if after the fasting level is 75, fasting level is 92 milligrams, and if after 1 hour it is more than 180 and more than 153 milligrams after 2 hours, we can diagnose medium. But if it is fasting level is 126 milligrams, and after 2 hours it is 200 milligrams, we call over diabetes. Or even if just random plasma glucose is 200 milligrams per day.
So now, whatever you use, actually best is to use DIPSI, because in India it is being said that universally one criteria should be used, so that a patient goes anywhere, everybody knows, okay, this has been used, but one must know the other. So now the patient is 175, and what are you going to do for her? Dr. Anju? Dr. Anju, are you there?
Or somebody
Hello.
else can take it if Anju is not having any.
So somebody
I'm here
else can
already.
take it.
Yeah.
Yeah, okay. Dr. Anju.
Shiba can take, or Dr. Mini can take.
Yeah,
so
anybody can take, because Dr. Anju is
I
not
think the
audible.
network is the issue.
Yes, ma'am. Ma'am, this patient.
Yeah,
Yes, ma'am. Ma'am, this patient has blood sugar is deranged, so that means she is GDM. We label her as GDM after this reports, and then we start with we counsel her. We start with her medical nutrition therapy. That is the mixture of diabetic diet and giving a concept of isometric exercises. So we have to make a in medical nutrition therapy that depends upon her weight and her lifestyle. We must assess her physical activity. So this MNT is individualized nutritional plan for each patient, and ideally it is a mixture where we distribute the calories over 3 major meals and 2 snacks over the day, and this must include each meal should include a mix of vegetables, proteins, and carbohydrates. So the carbohydrates mostly preferred are the complex ones, that is about 50 to 60%, and protein should be about 10 to 20%, and rest of the calories should come from the fat. And as I already told, this depends upon the weight of the patient. So if she's obese, then her calorie intake
that
would
has
be.
been very well explained by Dr. Vidya to me.
Yes, ma'am. Yes,
The
ma'am.
basic thing is that patient must be pushed on MNT. She must have distributed meals, not all meals together. And her thali should look like this, most vegetable. So MNT
Yes,
and
ma'am. And ma'am, isometric exercises. So physical activity is must for each this patient. And the maternal benefits would be that this would decrease the weight gain, improve her glycemic control, and prepare the physical rigor of labor. And also, it will later on contribute to decreasing the fetal adiposity. So the type of exercises are aerobic exercises and resistance exercises of moderate intensity of about 30 to 60 minutes. Generally, we describe the patients to do this for 30 minutes, and it should be the frequency should be no more than 2 consecutive days without exercising should go. So ideally, we say it is 30 minutes for 5 days a week that should she should target. And the
So
resistance exercises, so we explain her like she should, if she should stand, she can take 2 bottles of water filled with water, like 1 liter, and then she should do weight exercises, or she should try to push the wall. So that is also an isometric exercise which we tell her.
So she has done her exercises. And how are you going to monitor her while she's on MNT and exercises?
Ma'am, as per all the recommendations, when a patient is on MNT, we can adopt 2 approaches because mostly this is done in an OPD management. So either we do a 4-point Like we ask her to do a 4-point management. That is, she should do her fasting and then postprandial 2 or postprandial each after breakfast, lunch, and dinner. Or we can also follow that staggered approach. So generally, if the patient is following in OPD, so we and also in endocrinologists also they try that one day the patient can have fasting. The second day she does a post breakfast. The third day she does a post lunch, and then she does a post dinner. So that is also an approach which is followed these days. But it should be no more
Or
than
like
4 points.
just a
Yeah.
fasting, or just a fasting and PP 2 hours. So
Yes, ma'am.
she comes after 2 weeks. These are the findings: fasting 95, post breakfast 160, post lunch 140, post dinner 165. Now, what are you going to do?
So, ma'am, this means now, first of all, if she's not controlled, the blood sugar is not controlled, we must measure her weight, that whether she has gained excessive weight gain, that has to be ruled out. We should also check for the compliance, whether what all MNT we had described to her, like whether she is actually following the diabetic diet chart as prescribed, and ensure that the patient is doing isometric exercises. And if that has been ruled out, then the patient is already a candidate for pharmacotherapy. So we must opt for ideally the insulin or metformin, oral hypoglycemics.
So, like we had a good lectures on
Yes,
oral
ma'am.
and insulin. So, you're in pure practice now. Then this patient, what would you like to start?
Ma'am, actually, various recommendations, as Dr. Picky ma'am very beautifully highlighted. All the recommendations, they say that a patient who has first been diagnosed as GDM in pregnancy, she would require actually insulin, because the pregnancy is a diabetogenic state and the insulin resistance would keep on increasing as her pregnancy advances.
No, we are not talking about theory now. No, she is the patient. She's come to you. She has not controlled with MNT and diet. So, what are you going to start?
Ma'am, I'll start with insulin.
Insulin directly.
And any other panelist wants to differ with her?
So many patients now they are not comfortable taking.
Ma'am, if the patient, yes, ma'am. Ma'am, if the patient declines, she does not, because insulin requires injections.
Dr.
If she
Shiva, we
declines,
just
she does
now,
not.
this is just a revision. We just now
Yes,
had
ma'am.
very good lectures on
Yes,
oral
ma'am.
agent and insulin, and the DGCI also approving metformin. And this patient is little obese.
Yes, ma'am.
Here, insulin will probably increase her weight. And I think I would personally start her on metformin and not insulin, because we can see she is only 26 weeks. She's not more than
24 weeks. Yes, ma'am.
Yeah.
Yes, ma'am.
So we have enough time that we can give her metformin and see how she responds. Do the other panelists agree, or anybody wants?
Yes, we can start her on metformin because the sugars are not that high. It's 145, 165 like that. So we can always start on metformin and see.
Yeah, and the debate about glyburide, insulin and metformin, I think has been taken care by the previous speakers, that yes, insulin is the first line, but all guidelines now say that metformin can be started, and the kind of patients who come to us, you explain to them, of course, you have to tell them that insulin is first line, but this is how it has to be taken, and metformin is equally good, but we don't have long-term studies, and then start metformin. At least I would.
Yes, and actually even the Diabetes Association also have done a study where they found that there are so many diabetics in our country, but only 10% of people are only using insulin therapy, and everybody wants, newer drugs are coming and everybody wants the drug oral therapy. Everybody's scared of taking insulin therapy, and I think when we have this metformin with us during pregnancy now recommended, I think it becomes the first line unless and until it's uncontrolled or we have any other reason to start insulin therapy.
So how do you start it, Shiba?
Ma'am, so ma'am, metformin or insulin?
Yeah,
metformin we are talking about now.
So, ma'am, metformin is started with a 500 milligram dose, and we slowly escalated according to the blood sugars. That is 500, 500. We step up by each 500, and the maximum dose which is given is 2.5. So
And
that's
then
how we
if
give.
you are not able to control it with that, then you can add insulin.
Then she should be switched on to insulin or added on that.
Then how do you monitor once you have got a good control?
Ma'am, so ideally, after a good glycemic control is achieved, once a month monitoring is optimal, especially in the LMIC countries.
Not optimal, but can be done. Optimal is every 2 weeks.
Every 2 weeks, yeah. Right. And
And
this is
then,
till 28th week, and then after in the third trimester, it has to be done every week.
yeah. And then again, that staggered approach of 4 samples or
Yes, ma'am.
1 day 4 sample, whatever the patient prefers.
Yes.
In which patients you will not start metformin?
Ma'am, if the patient has any significant organ dysfunction, if there is fetal growth restriction or macrosomia, either of them is available. If there are associated hypertensive disorders of pregnancy in the patient, if she has a high risk factor where any time a preterm delivery is entailed, and also in the first trimester. So especially because Government of India guidelines till now they said that it can be started only after 20 weeks. But though recently only the CDSCO, as Picky ma'am highlighted, has said that they will change it and it can be also continued in the first trimester also.
So
Because enough
when you
safety
start,
data is not available.
yeah, so when you take a decision for metformin, look at these sectors. Like very nicely, Dr. Sujata has pointed out that it can cause the metformin. These oral agents can cause FGR or preterm labor. So these patients, they should not be started.
Yes, ma'am.
Any role of doing HbA1c in these patients?
Ma'am, HbA1c actually again different guidelines say, but they say that HbA1c, Dr. Charmila had also highlighted it earlier. HbA1c level monitoring is not ideal in pregnancy because of the hemodilution which occurs in pregnancy. So also there is little data on this use of HbA1c for monitoring, and we just basically we use HbA1c for diagnosing GDM or pre-gestational diabetes. It is not for
If early pregnancy you have a patient with high levels,
yes,
then
ma'am.
probably you can or it also predicts that if you want to do it once every trimester, it will only predict the risk of fetal or
Adverse
maternal
maternal or
complications.
fetal effects. Yes, ma'am.
You don't use it for screening or control of sugar. And besides that, in a patient of diabetes, besides routine investigations, you're going to start her on metformin. You want some other investigations also?
Yes, ma'am. We must start with, we must undertake tests like LFT, KFT, her urine routine and culture. We should do a
We don't
TSH.
Yeah, TSH we do routinely, but LFT,
Yes, ma'am.
KFT we don't do routinely in ANC. But if we are going to start her on metformin, we should be sure that she doesn't have any problem. So at 33 weeks, patient goes and has come with labor pains, having mild contractions. Now, Dr. Sudha, we want to give her steroid. Steroids, we know, will increase the sugar. So what should we do? Dr. Sudha?
I can't see Dr. Sudha. Is she there?
Anybody else want to take it? Minnie?
Or is like, can you make her a co-host if she's not added? Dr. Sudha?
Steroids can be added because usually the lung maturity is not great in case of diabetes or even GBM. So we should add it. And if the blood
The Alpana Chetri is also
Yes.
joined. Kindly unmute
I've
her.
joined this. Yeah, I'm.
Fine.
So question is Dr. Sudha is not.
Yeah, so if you're giving steroids, one thing you should think about is monitoring the blood sugar because her sugar can rise and she has to be monitored for at least a week after the steroid administration. Too much, she may even
Not a week. I think 72 hours is enough once you stop. You don't need to do it for a week, but you might have to increase the insulin dosage by 50% when you are giving. That you have to see according to her blood. But she has to be very strictly monitored for blood sugar level because steroids will increase. So fetal monitoring.
Dr. Alpana?
Yes. Yeah, I'm in the yes.
Yeah. So what fetal monitoring you want to do in this patient?
Fetal monitoring, actually, it will be starting from her first trimester monitoring regarding her NT scan and dual marker, and we come to anomaly scan. And after around 19 to 20 weeks, we do an anomaly scan. And it is mandatory to go do a fetal echo. Echo might be very necessary in this fetus in this patient. So I would go for a. But one thing is that you if and there should be if there is some evidence of IUGR, if I find clinically or if I find evidence of IUGR, you would go for color Doppler. I would like to go for a color Doppler, fetal color Doppler.
When will you start the fetal monitoring, like we do DFMC and modified by physical?
Yes,
when do you want to start it? Or do you want to start it?
If I routinely in antenatal cases, if I find the patient is okay, her weight gain is okay, and her clinical parameters are okay, I would like to go for a Doppler monitoring after 32 weeks.
There is some problem with the audio. I think we are getting a lot of
the audio is
regarding the
not
audio. I
good.
don't know what is the disturbance. So, please let us know. Only I think those who speak will on it so that we know from where the disturbance is coming. So, I think this question, Dr. Alpana and the rest of we'll unmute ourselves.
Yes. So, can you hear me properly right now?
Yeah. Now we can hear you. So
actually,
Doppler is only required if there is evidence.
Right, when evidence of IUGR, I'd go for Doppler, and
Otherwise,
growth scan, I would go around 28 weeks. I would go for a growth scan.
Yeah, and then you will have to
At
repeat
28
it
weeks.
probably. Sometimes you miss out the macrosomia.
At
So
least
32
4
weeks,
weeks,
33
yes.
weeks. And you also look for Leica because they can be polyhydramnios which you may miss. And except for DFMC, if a well-controlled diabetic you don't really need to do extensive monitoring for the baby in that case. Yeah. But one thing, Dr. Shashaya has come out with the early in 8 to 10 weeks, if you do a PP sugar, and if it is more than 110, he says that it predicts gestational diabetes later in pregnancy, and you should start those patients on metformin. He's working on it. The paper has come, but it is still, needs more studies, but I thought I'll tell you that. So patient remained well controlled, went into spontaneous labor at 37 weeks. How will you manage it? Intrapartum management. Minnie?
So if she is on insulin, we do not give her insulin at that time. We'll only monitor the blood sugars and give insulin accordingly. We have to monitor with the regular GRBS should be sufficient every 1 to 2 hours in active labor, and we have to keep them well hydrated. And I feel that the oral intake should not be stopped because that could be a reason for the starvation also. And good IV fluids to be given, and generally they do well. And if the blood sugar is not controlled, the baby is also going into trouble. So we need to. This is the sliding scale which we use. And we give it in normal saline. The insulin is to be given in normal saline, and it is all given here nicely. And if the sugar is less than 1, if the blood sugar goes down, then the 5% dextrose is started, so the baby does not go into hypoglycemia once the baby is born.
So it is very important. Hypoglycemia is more important than hyperglycemia in causing sudden fetal death. So we should be following her very carefully, and these scales are there everywhere, so you should be following it. Dr. Sudha, now this patient has delivered. How are you going to take care of her? Dr. Sudha is not there? No?
No, she will join. She has joined, ma'am, initially.
Dr. Sudha, so unmute her or do something because already.
Ma'am, Sudha ma'am is not joined yet. Sudha Rani is there.
Sudha R.
No, ma'am. She's
From
not.
Mysore.
Yeah, she's Sudha only. Even today morning, she got the link and she said that she joined from Mysore.
Sudha is from, I think Dr. Sudha, is she
From
there?
Mysore. From
You
Mysore.
can just put a comment in the chat box. We will unmute her. In the meantime, I think somebody can just go ahead with the discussion.
I'll call her and check.
Yeah.
Again.
Yeah. So,
So postpartum, in a case of gestation diabetes, we find that the blood sugars come down immediately after delivery. But if
Yeah.
it's already diabetic patients, that the blood sugars do come down, but still we have to follow them up. And for a few days, maybe they would be all right, but gradually they tend to increase. And so GDM, and we have to repeat their blood sugars later on also after 1 week, and then later on at 6 weeks also we do repeat the blood sugars to see if the blood sugars are going high. In GDM, generally they become normal, but they run the risk of developing type 2 diabetes later on in their lives. So we have
So
to
promoting weight loss, postpartum advice is very important for them, that they have to maintain a healthy lifestyle with diet and exercise. They have to be told that they have high risk of developing GDM and other metabolic complications. So they should be getting their blood sugar checked, of course, after 6 weeks and yearly, and they have to be on check because, and this advice, if you don't get them,
Sir,
they're
you're joined online. Please.
Dr. Komal, will you take the second case?
I'll start now. So we now moving on after the comprehensive case one. Now we have a 35-year-old. She is a first-time pregnant, primi gravida, comes at a 9 weeks pregnancy. Her height 159 centimeters, weight is 60 kg. And we give her on the first visit 75 gram of glucose, do a DIPSI test, it is 165. So now everything we know, we have so much spoken about it. Is there a role of HbA1c here, Dr. Shilpa?
Yes, ma'am. Actually, HbA1c, as we told, it is important for predicting the adverse fetal and maternal outcomes in a woman. So we must counsel her about the effects of HbA1c if they are very high. So generally, the cutoff which we take for diabetes is more than 7 and 6.9%, more than 7. And if it is more than 10%, then the risk of malformations is the highest. So we must tell that patient.
So we need to counsel on the basis of the HbA1c, what will be the fetal outcome. So non-diabetic early onset, we really need to do the HbA1c levels to counsel it. So what about the further management? Can you continue anything you
Yes,
need
ma'am.
extra
So,
apart
ma'am,
from what
further
we are
management,
giving?
we must for such a patient, we must as it previously told, we must advise a thyroid profile, a 24-hour urine protein fundus, an ultrasound KUB, KFT should be done, and patient should be counseled regarding the risk of complications. And then we must also counsel the patient, because counseling is important. Apart from the fetal complications, she should be told about the risks of increased frequency of obstetrical complications in such patient. And if the patient is uh, uh, she would be requiring insulin and how that has to be given, so she should be told about everything.
Yes,
And
you
since
rightly
she
said
has
it
got
The glucose
diabetes
monitoring. Yes, ma'am.
in first trimester, most likely she was an undiagnosed diabetes
Gestational
with
diabetes.
diabetic complication may have been present in her in early stages. So you have to do certain organ functions.
Yes, ma'am. We
Uh,
must rule out diabetic nephropathy, and we must do these tests to
it is very important because this
retinopathy is
may be
also to be ruled out.
pre-existing, and pregnancy it can get aggravated. So we need to know her status. So you have rightly pointed out that, and plus your HbA1c level, which is going to help us in the management. What about the take on insulin? Like, how do you decide? Like, how do you start the insulin therapy in these patients?
Yes, ma'am. So this patient is an ideal candidate for insulin, and generally it does not, as ma'am had already told, the requirements of insulin in such patients, they would go from anywhere from 0.7 units to 1 unit per kg per day. And see, we start from the lowest possible doses, and as per the blood sugar profile, we keep on escalating these. So, an
Here
insulin
I want
regime,
to point out, I've had that experience of, like this kind of patient starting 0.7 and patient
Yes, ma'am.
went into hypoglycemia because that
Yes,
dose
ma'am.
is for insulin dependent patient pre-pregnancy, not for
Pre-pregnancy.
patient whom we don't know what she is. When
Yes,
they
ma'am.
don't have any insulin, that is the total requirement. This patient, we don't know how much, what she is. She was not on insulin earlier. So these patients, we have to start with the lower dose and go higher and not
Yes,
start
ma'am.
with 0.7, 0.8, 0.9, which is written. That is only for those patients who are on insulin before pregnancy, not for a
Yes,
patient
ma'am.
who is just diagnosed.
Yes, ma'am. And ma'am, the Government of India guidelines, they say that we should start with mixed-ard insulin, and there are various multi-dose infusion insulin which are available
Good lecture from Picky.
on the yes,
short
ma'am.
acting and long acting, because short
Yes,
acting
short
will
acting and
meet
long
the
acting.
initial need, and long acting will maintain the sugars. So I
So,
think
ma'am,
mixed
depending
diet
upon whether the patient's profile, if her fasting is high or her post lunch is high or her post dinner is high, we should start the insulin accordingly. So, if the postprandial is high, we generally start with the regular insulin, which is short acting bolus. And if the post dinner is high, then she should be getting an NPH in the morning. And if her fasting is high, then she should get an NPH in the night.
And in these patients, very important that before you start her on insulin, she and her family must be consulted about the signs, symptoms of hypoglycemia.
Hypoglycemia. Yes, ma'am.
And she should always have some sugar ready with her. And
Yeah.
depends, we have a various kind of clientele. In government, you are all right. The Government of India guidelines are very good, which tell us about regular insulin and pH. But now we have this, Picky has very beautifully told about the insulins, this Aspart and Lispro. These are insulin analogs. They are much better than the regular insulin because the onset of action is early and the last 3 to 4 hours, which is very good. And of course, the longer acting ones are also there, which these are all analogs, insulin, detrimer, and Degludec. If patient is already taking it, then she can continue. Otherwise, we start, like you said, on regular, do the 7 point. When you start on insulin, it's very important that you do the 7 point
7 point
glucose taking, because at 2 a.m. she may go into high.
Yeah, we have to, yes.
Evening, that 2/3 in the morning, 1/3 in the evening, and the morning again has to be 30-70, 30 long, short acting and 70 long acting, and night has to be 50-50, and she must take something at 10 p.m. so that she doesn't get night hypoglycemia. So it's very important if you're starting insulin. And another thing, whenever you have these patients, you must do it multidisciplinary. You must have a fetal medicine person and you must have a diabetologist on board when you are seeing these patients.
Yes, ma'am.
And the monitoring is very, very important.
Nicely, you have already said.
How the chart will look like. So how often do you monitor these patients? Because I think
So,
Dr.
ma'am,
Sharmila has spoken very well about all the monitors, CGM and everything. But a typical patient who comes, pregnant patient who doesn't have all those, they need to maintain a nice chart. So can you just explain, Dr. Shiba?
yes, ma'am. So, ma'am, these days, even our endocrinologists, they recommend the staggered or rotatory monitoring profile. This is 7-point profile is done on a patient for a patient on insulin, but it is generally done like on a starting from if Monday starters. So, she does the before breakfast and after breakfast on Monday. Then on Tuesday, she will do a pre and post lunch. Then on Wednesday, she will do a pre and post dinner, and then on Thursday, she repeats the same cycle. So and on Sunday, she will do a full 7-point profile, which is done once a week. So this ensures that her blood sugar variability over a period of week that can be monitored ideally.
Yeah. So earlier we had the olden concepts where everybody was doing every time they used to mark and prick and everything. And now we have these things in check. If the patient keeps monitoring religiously, if this monitoring is done, this can be better to even titrate the dose. And this also holds very, very good. So now this patient was started on insulin and the control was not optimum. So any better way to monitor her control? Like continuous
Yes,
monitoring
ma'am.
we
So
spoke.
the continuous glucose monitoring is the current role which is done in such patients where the blood sugar profile is not coming normal and it is deranged. And then we also have a role as Ma'am Picky has already explained of the ambulatory blood glucose profiling also.
Yes.
So these are also done. But we must ensure that the patient is compliant and her diet with her diet and exercise schedule and her lifestyle is rectified as well. And
Yes.
for these ambulatory blood glucose monitoring, we use those sensor-based monitors, and otherwise we can do it with the calibrated blood glucometers.
But one thing important is when you're using a calibrated glucometer, every 2 weeks you must, do a
Recheck
lab
the calibration. Yes, ma'am.
just to see
Recheck the
that
calibration with a concurrent venous sample.
Yes, it has to be checked.
Yeah,
And
after
even
every
the
2 weeks.
small monitors which you can we get it, you can just put it, and it is based on a sensor, and you get portable. I think they come around say 5,000 rupees, and so you can just put those monitors, and they are there for 15 days. You don't have to worry. They give you the reading, they give you the graph also regarding, and they send alerts regarding hypoglycemia. They send alerts regarding hyperglycemia, so they have a safety range. So whenever the sugar falls down, you get an alert. So the patient knows that there is an effect of hypoglycemia. They can eat it. And later on, if there is a 180, if it goes, then it will show again a window. So that is all. And it is very, very freely available now. That is the Abbott.
Other advantage is patient can also keep a chart of what she's eating, so she will know what she ate, which has caused that high
Yes.
variability.
And there
That
is a
also
graph which comes after you use it for 10 days. There is a nice graph. So they share a graph. So we also know the pattern, what time it is fluctuating and everything. So it comes very
And
nicely.
what meal triggers her hyperglycemia, that can also be
Yes,
controlled.
yes.
And this eventually leads to lesser insulin injections also, and better patient adherence.
Yes. So now coming back to this case, she presented at 28 weeks with complaining of headache, restlessness, and you see some parameters have risen, like the BP is now 140/80. So Dr. Anju, now you have to step in. So tell us, how will you manage? Dr. Anju or Dr. Alpana, you can take it.
Komal, I think
Yes.
Dr. Sudha has joined. You can
Yeah,
call
Dr.
her.
Sudha is there.
Dr. Sudha can take it then,
Yeah, then
because
Dr. Sudha can give us.
Sudha, are you there?
Yes, I can see Dr. Sudha. I can't see her, but I can see she's there. So,
Yeah.
Dr. Sudha or Dr. Alpana, any one of you who can hear me?
Actually, whenever this type of symptoms very rare that the
I can hear
patient
you.
is developing hypoglycemia or not. Yes. You have to be very sure that if she is developing hypoglycemia or not. That is more dangerous than hyperglycemia itself. So that might so she and whenever you have to counsel the patient that you have to say the symptoms of hypoglycemia, you have to counsel her, and when anything of that sort happens, she needs to take some sugary food, or toffee or any chocolate of that sort. So
Yes.
that is very important. So first of all, yes. And regarding her blood pressure, I don't think so. Blood pressure is that it is high, but not to that level. So she could maybe monitored with blood pressure after some time. At least 2 readings should be there in order to diagnose if she's having hypertension along with diabetes or not.
Yes, yes. So
how will you manage her hyperglycemia? What will you tell her that what she has to do when she has these symptoms?
Practically, we always, as in my settings, we always say that if you have something, you always keep some sort of sugary stuff with you, because and she's well explained about the hypoglycemia part. But and suddenly if she has this, so so she should at least put some, or she should if she is if there's glucon D and glucose powder is available, she just makes it, or anything at home, even.
Yes. So I think they need to be educated well about the hypoglycemia, because that is more important when you are putting a patient on insulin therapy, and hyperglycemia. We are
So
not
this
that
is what
worried.
you have. The symptoms improves. Yeah, the symptoms improves after having any sort of this type of drinks.
And
And
an important
if
thing
it will
is that after having taken the glucose, this high glycemic index glucose or sugar, she must eat a chapati, rice or milk, so that this sugar rush which will probably cause more insulin release. So that is this eating is important 15 minutes after taking the glucose. That is a very important point you have to tell the patient.
So now, Dr.
Dr.
Shiva,
Shiva, yeah.
this
Now
is
we
a
have another
diabetic
patient.
controlled on Gargain insulin and she conceives. She wants to plan pregnancy. What is to be
No,
done?
sorry, Komal conceive is not there. She wants to plan pregnancy.
So she wants to plan pregnancy. So she's come for a preconceptional counseling, a very nice educated patient. So what is to be done? Will you change or you can continue it?
Ma'am, initially the safety of these long-acting insulins was not proved, but currently we have a lot of literature which says, especially there are many studies on these long-acting insulins from 2023 and recently in 25 also. So if the patient is well controlled on such long-acting insulins, these can be continued. And there, besides this, the other concepts of preconceptional counseling again remain her achieving optimal glycemic control, education about diabetes in pregnancy, the adverse effects, what pregnancy would entail, and when she on her glycemic status once she gets pregnant, and till her optimal blood glucose control is not achieved, she must practice contraception, and then what all she must some certain tests she has to undergo, and how frequently she would be requiring monitoring in the antenatal period once she conceives, that also has to be explained to her. And apart from that, the risks of maternal and fetal complications, especially the fetal complications if her HbA1c is quite high in the first trimester.
Yes, I think you have summed up very nicely, and I think there was an alarm of the timer. But what we have, Dr. Sudha also has joined, so we want more insights from her also. Dr. Sudha, welcome.
Yes,
And
ma'am. Good evening.
yeah, good evening. Good evening.
So
So
we were talking about preconceptional evaluation of the patient who is on insulin.
Okay, ma'am. Now, what I learned from the endocrine and the present guidelines, there is no strict rule for the insulin per se. And they are saying it is always better with OHAs only. First line is MNT, second line is OHAs, third line is OHA plus insulin, like that they are telling. So there is no particular thing, madam. It is all tailor-made. Depends on the patient and how you are going to treat her. Suppose she is pre-gestational diabetes, we have to look into her
Madam, we want to
HbA1c
know what
values.
advice you will give her for during her preconception before she conceives. She's already on insulin. So what advice you will give her? What all she
Yeah,
should
madam,
get
better
done?
she continues insulin in the first trimester as far as possible. I'll not switch over to OHAs in the first trimester. Though the evidence says there is no teratogenic effect with this thing, but still you need CDC guidelines and the FDA. You need to have an ethical clearance if you want to put them on OHAs when you are putting treatment on them, OHAs. So if she's on insulin, better let her continue like that only in the first trimester. And
Yes.
later on, depending on blood sugars, I will think over whether to change over to OHAs or to continue with insulin.
So, and we must review her medications, which she might be taking if she is
Madam, it is
pre-gestational.
not the single person, sir. It is a multifactorial approach. You
Yeah.
need to have an endocrinologist, ophthalmologist, neuro, and nephro, plus a gynecologist, because she's a case of over diabetes. So we need to have many specialties in one.
We have to know that we have to have them, and we have to know what they should get done. Like retinopathy fundus should be done at once in every trimester.
Fundus.
You must do urine albumin to creatinine ratio to see if she's developing any microalbuminuria. And of course, she has to be given lifestyle, nutritional counseling, healthy eating,
And
physical
renal
activity.
Doppler also is a must, madam. Renal Doppler to know any other cause for hypertension. And you need to have on 2D echo, begin with, as a screening for her.
Yeah.
Because they'll be more prone for end organ damages, depending on the years of diabetes, how they are suffering. As per the White's classification, we have to look into the cases. And purely it depends on FBS and PPBS. Both we have to look into. So many things we need to do, ma'am, for them.
So yeah. Right. Dr. Komal, you can continue.
Yeah. So now coming back to the case, her insulin dose was increased as pregnancy progressed in consultation with diabetologist, and she presented at 28 weeks with high-grade fever for 2 days, restlessness, extreme thirst since morning. So now, Dr. Mini, she comes to you, and now what do you think more in like on lines of diabetes?
Yeah. So since she's already diabetic with insulin and she's having an infection, it's most likely to be a diabetic ketoacidosis. So they have this kind of increasing thirst because they're volume depleted, polyuria, polydipsia, and abdominal pain is something which we always have to look out for. If there is abdominal pain, then almost always it is diabetic ketoacidosis. And there can be a change in mental status. They can be sort of delirious also when they come. So, and you find that the blood sugars may not be as increased as in a normal diabetic ketoacidosis. It may not be higher than 200 also. Still, they can have ketoacidosis.
Yes.
So, always, if there is ketone plus, even if the blood sugar is normal, you have to think about diabetic ketoacidosis. And they
So what
always
will you do for her now?
yeah, she has to be in the HDU, and we have to have a multidisciplinary approach. The endocrinologist has to be involved because the IV insulin is the drug of choice, and then we have to give. It may take 24 hours or longer also with IV insulin. It is not just euglycemia. The ketones have to go completely, and only then you can think of stopping the insulin because the treatment will be prolonged. Lots of IV fluids is required, and yeah, electrolyte correction sometimes the babies can also be affected because there is acidosis for the fetus as well. The NST can be very deranged and all that, so it is an emergency. It has to be treated properly.
Yeah, so while you are calling the endocrinologist, basically you should get certain investigations done, the sugar, the electrolytes, the ABG, and the potassium, so that when the endocrinologist comes, he can immediately start the treatment if you don't want to start. Basically, you have to give them fluids and you have to give them insulin. And if the potassium is low, you have to correct and you have to do continuous fetal monitoring if the patient's gestation age is such more than 28 weeks. And if there is something wrong in the CTG, you should avoid immediate delivery because as you will correct her hypoglycemia and give her fluids, it will improve. So you wait for some time after correction before you take any action regarding the fetus.
So I think we will move to the post test. I think everybody's asking for the post test. Doctor.
Okay, this is just a simple last
Yeah,
case
you
that
can just
No,
finish
no,
it
madam,
with the
madam, no, we have to start the post test
post
because it's
test
already
because the
7
time
now.
is up. We need to have the post test.
People will have to go for their this thing, madam. So I think we'll have to stop.
Okay, I think most of it is covered. It was just LSCS, which everybody knows how.
Okay.
Yeah, we'll go for the post test now.
Komal, will you take the post test? She'll
Yes,
say
I'll
it.
be doing it. So can you show the link or the QR code? Thank you so much, all the panelists. I think it was an excellent interaction with everybody, and we have a lot of doctors, our consultants, and medical students are glued, and they are waiting for the post test. It was a very informative discussion today. So, can I have the ICOG team? Can we just show the
Ma'am, Kavita ma'am, what about postpartum management? The question was supposed to be asked to me.
Sudha,
will
we
be
can't
there at
cross
the-
the time because we have to start.
Okay,
Dr.
okay,
Sudha,
okay, no
you
problem, ma'am,
joined
no
late.
problem.
We covered it a bit.
I was in a meeting with
discuss it,
medical education minister. I had taken a video conference meeting. I'm the
Okay,
medical superintendent of Chalvamba Hospital, madam. Please forgive me.
Okay, no problem.
Yeah, okay. Thank you.
That's why I joined late.
No problem. The link has started. You have got 15
link
minutes.
is started.
Please
See in
answer.
your chat box, the link is there by Shreya. The form which we can see, everybody can log into the link and do the post test. And this is a QR code if anybody is having the difficulty. And we can have a time. Yeah.
10 minutes, Komal?
Still time is there. We'll have to wait. 8
All
more
right.
minutes.
Okay.
So, hello. Yeah, so now we have finished our session and the post test also. We will share the answers soon. We have Dr. Parag Biniwale, our ICOG chair, till the very end. I can see him.
Thank you, Komal. Good evening. I hope all of you have enjoyed the learning session today. I must appreciate my team. Excellent efforts put in by all the three conveners. I'm so happy to see all three of them sitting here for last 3 hours plus. Thank you, Charmila. Thank you, Komal. Thank you, Achila. And of course, today's coordinator, Jayarani. Thank you for being there. And I'll see you again tomorrow at 4 o'clock with on the third day of certificate course. Please don't forget to attempt the questionnaire which will be given to you tomorrow. And then those of you who secure more than 50% marks and attend all 3 days will get a certificate in a month's time. So thank you very much. Komal, over to you and Jaya for the answers. Thank you.
Thank you, sir. Komal, unmute. Unmute, Komal.
Yeah, thank you so much, Dr. Parag sir. And I think everybody is waiting for the answers. And we have the answers to all the questions. Shreya, can you just display because I have it or I can read it? So the first question was, in Government of India guidelines, how often should the patient test her blood sugars if she is on metformin? And the answer is once in 3 days. Then coming to the continuous glucose monitoring is based on what technology? It is flash glucose concept.
Can you share the screen, Komal? It'll be easier for them to follow there.
Shreya?
Shreya, please share the screen, the answers.
Ma'am, there's some technical glitch from her end.
Oh, okay.
Yeah, she's
Just
rejoining.
share as in
Yeah.
like you do it. In the meantime, I'll just
Yeah.
talk about it. Then coming to the CGM, that is a flash glucose concept. Then the third question, ambulatory glucose profile is a graph built over how many days? So it is 14 days. CGM is most useful in management of type 1 diabetes. That is the fourth question. Then fifth, most common congenital defect in fetus of diabetes mother, it is cardiac. Sixth, risk of congenital malformations highest when the HbA1c levels are more than 9. So coming to the sixth question. Yeah, seventh question. Fetal macrosomia is defined when fetal abdominal circumference is more than 90 percentile. Cutoff of anterior abdominal wall thickness in normal fetus is A 2.5 mm. Ninth question, best method of predicting stillbirths in pregnancy with DM is actually none of the above. So 10th question. Yeah. When should pharmacotherapy be initiated in hyperglycemia during pregnancy? The answer is C, if glycemic control targets are not met after 2 weeks of MNT in second trimester. 11th, which insulin types are classified as basal, background insulin? These are the NPH, detemir, deglutic, that is B option. 12th, how should insulin be titrated if the fasting blood sugar remains high? You know, the answer is C, add NPH or detemir at night. Then coming to the 13th number, in pregnant women with type 1 DM, the insulin requirement in third trimester is approximately 1.2 units per kg per day. Then coming to the 14th one, in elective cesarean delivery for GDM on insulin, what should be done preoperatively? Omit the morning insulin dose and monitor her sugars. Postpartum women with GDM should stop insulin and monitor glucose. Then 16th number, which of the following is a primary dietary goal in managing hyperglycemia during pregnancy? The answer is C, maintain normal blood glucose level through balanced meals. 17th, which type of carbohydrate is most recommended for pregnant women with hyperglycemia? Yes, it is complex carbohydrate with high fiber. 18th number, what is the recommended meal pattern for pregnant women with gestational diabetes? 3 small meals and 3 snacks per day. Then coming to 19th number, which of the following nutrients should be carefully monitored due to the risk of large for gestational age infant in GDM? Carbohydrates. And the last one, what is the role of medical nutritional therapy in gestational diabetes? The answer is, it is a first line approach to managing blood glucose levels. So these are our 20 questions for today. And you will get your results in a day's time. And also the above 50% will definitely be getting a certificate. And you need to join tomorrow, because we will again have the medical disorders. All the mixed medical disorders will be discussed in a very, very interactive session. So from ICOG team and everybody, I thank all of you for joining today. And we see you the same time tomorrow. And learning will always keep continuing. Thank you so much for everybody. Thank you, Jayarajani. She was fantastic today. Very, very nicely coordinated today. And Shreya from ICOG and all the senior faculties. I can see Dr. Achala, Dr. Shobha Goody, then Dr.
Komal,
Vidya, Dr. Shiba,
Komal.
everybody there. Yes. Now
Can I
here
can मैं आपको उनका सही नाम बताती हूँ. उनका नाम जय रानी है.
Yeah, I think she has given me a new name in ICOG. Komal has given
Yeah,
another
yeah,
name.
no, you have made her winner before the
Everybody
election.
will spell something different or say something.
So cute. I found that error very cute, actually.
Yeah. So what happens now? Now she will be more noticed.
I think you have increased her popularity by several.
Please look at the chat box, Komal. It was excellent. This one.
Very
Please
nice.
Chat box.
Thank you. So see
Thank
you
you,
all.
Komal.
Bye.
Thank you.
Bye. Bye.
Very, very well done. Komal and Jayrani,
Nice,
Achla,
it was.
everybody.
Today's
Very nice.
session was excellent. Excellent.
Very
Yeah,
Thank you. Thank you
Thank
for
you.
making
Thank you
it
so
happen.
much. Thank you.
Yeah, yeah, yeah.
Thank you all the senior. Thank you,
Thank you,
senior faculty.
Achila.
Thank
Thank
you.
you.